wabarakatuh, semua warga UiTM. Individu yang positif berkenaan, kita kategorikan dia sebagai A kerana dia adalah positif COVID-19. So, siapa yang berhubung rapat dengan COVID-19, positif COVID-19, kita kategorikan dia sebagai kategori B. So, untuk kategori B ni, mereka kena melalui ujian COVID-19 untuk disahkan sama ada ujian mereka positif atau negatif. Sekiranya mereka positif, dia akan jadi kategori A pula. So, kalau dia negatif, dia bebaslah. Tetapi kategori B tetap kena kuarantin untuk 14 hari. So, mereka kena kuarantin di rumah selama 14 hari. Arahan diberi oleh bahagian pejabat kesihatan daerah. So, untuk sesiapa yang berhubung dengan kategori B yang sedang menjalani swab dan sedang menunggu keputusan, mereka adalah kategori C. So, sesiapa yang kategori C ni di dalam pejabat pun ada, di college pun ada, pelajar-pelajar pun ada yang kategori C. So, kita nasihatkan mereka juga perlu buat home isolation ataupun isolate diri di rumah ataupun di college masing-masing sehingga semua individu yang kita berhubung tadi, yang kategori B tadi dapat keputusan. Sekiranya B itu negatif, maknanya anda semua bebas yang kategori C. Bebas boleh datang kerja semula. Tapi sekiranya individu kategori B tadi positif, dia dah menjadi A. Jadi anda yang C ni tadi telah menjadi B dan anda mulalah kena swab pada tarikh-tarikh yang dimaklumkan nanti oleh pejabat kesihatan daerah. Untuk anak-anak pula sesiapa yang kategori B yang kita telah buat swab, anak mereka, ahli keluarga mereka adalah kategori C. So mereka pun sama. Mereka kena home quarantine ataupun isolate diri di rumah. Tapi bila kategori B tadi yang telah swab tadi negatif, mereka boleh balik ke sekolah. So janganlah risau. Dan kategori C juga, siapa yang balik ke rumah, anak dia adalah kategori D. Mereka boleh bebas pergi ke sekolah ataupun pergi ke mana-mana, tetapi mengikut SOP yang telah ditetapkan oleh Kementerian Kesihatan dan juga MKN.
For 60 years, University Technology Mara, or UiTM, has been the place for acquiring knowledge and developing capabilities. From a training center to now a vast network of universities, UiTM has campuses and faculties all over Malaysia. UiTM allows for the pursuing of goals and earning a degree in any field of choice, with a mission to enhance the knowledge and expertise of Bumiputras in all fields of study, through professional programs, research work and community service, while upholding moral values and professional ethics. Nestled amidst the greenery and some of the most scenic areas in the country, each university campus is strategically located in places where their presence inevitably provides an economic boost to the local community. The Vice-Chancellor is the Chief Executive Officer, heading the academic and administrative management of the university. UiTM pledges to provide maximum opportunities to pursue professionally recognized programs of study in science, technology, industry, business, arts and humanities. University Technology Mara offers quality education at all levels of study, from foundation to postgraduate. The university has always been at the forefront in science and technology, as well as in management. It is a place where talent, skills and excellence are nurtured. UiTM has a mission to empower the indigenous people through the provision of higher education in accordance with Article 153 of the Malaysian Federal Constitution and Act 173, University Technology Mara Act 1976. Duli Yang Maha Mulia, Seri Paduka Baginda Yang di-Pertuan Agong yang ke-15, Sultan Muhammad V, is the Chancellor of UiTM by virtue of his status as the King, as provided for by the law. UiTM offers 500 programs which are conducted at 24 faculties across 13 state campuses and 21 satellite campuses all over the country. Aimed at producing highly motivated and accomplished doctors with a solid scientific foundation, imbued with strong humanistic values, the Faculty of Medicine is committed to provide quality education that is actively engaging for the students, so as to produce doctors who will lead the medical profession in the future. With full support from the government, the faculty is equipped with strategic research facilities and infrastructures to support teaching, learning and research, ranging in areas of molecular and basic clinical sciences to clinical trials and epidemiological studies. Established in 2006, the Faculty of Dentistry has gained national reputation for its excellence. In addition to its first professional degree, BDS program, the faculty offers postgraduate programs in research and clinical doctorate. The Faculty of Pharmacy's strategic vision is to become the center of excellence in pharmacy education and research in Malaysia, in line with UiTM's aspirations to produce world-class and holistic graduates. UiTM offers programs in 4 engineering disciplines, namely mechanical engineering, electrical engineering, chemical engineering, and civil engineering. At the Faculty of Applied Sciences, conducting experiments and laboratory work are the main methods of learning. The students are trained to develop strategic thinking attributes and skills and extend their learning experiences beyond academia. The Faculty of Hotel and Tourism Management, one of the pioneer faculties in UiTM, was established in 1967 at the Jalan Othman campus, Petaling Jaya. It is a leader in hospitality education, offering courses of all levels, from diploma to postgraduate. The Faculty of Accountancy has come a long way since 1956 with the setting up of the Rida College in Jalan Othman, Petaling Jaya. The faculty is the first in the country to offer the Association of Chartered Certified Accountants, ACCA, in 1967, along with diploma and later degree programs in accounting soon after. UiTM is the first institution of higher learning in Malaysia to offer programs in the field of sports management, leisure, recreation, and sports science since 1995. In 1996, the faculty offered Master of Sports Science in collaboration with the University of New South Wales, UNSW Australia. This was the first postgraduate
Assalamualaikum warahmatullahi wabarakatuh. Semua
For 60 years, University Technology Mara, or UiTM, has been the place for acquiring knowledge and developing capabilities. From a training center to now a vast network of universities, UiTM has campuses and faculties all over Malaysia. UiTM allows for the pursuit.
Hey everyone, today I'm going to show you some easy exercises as well as some stretches that you can do whether you're at home, at work, whenever you need a little break so that you can maintain a proper posture for the health and strength of your back. Let's get started. The first thing that you want to keep in mind is your posture when you're sitting down, especially at your desk. You don't want to slouch, but instead you want to be upright. You gotta keep your chest up, your head up, your back straight, and your shoulders up. Also, remember to take a little break every hour or so whenever you're working or whenever you're gaming. Now, for some exercises that you can do, you gotta keep your back straight and you can roll your shoulders backwards for a set of 10, and you can also roll your shoulders forward for a set of 10. So 10 forward and also 10 backwards. Lastly, you can do the stretch at your desk. You can put your hand above your elbow and you can stretch your elbow. Lastly, you can do this stretch at your desk. You put your right hand above your elbow and you pull it down and you drop your head at the opposite side. You want to hold at this position for about 10 to 15 seconds. This will be able to stretch out your trapezius muscles and help you to relax your back as well as your neck. These are little stretches that you can do right at your desk. Remember, posture is really important, so keep your back straight, your chin up, and your shoulders square. Next, I'm going to show you some tips and eye exercises that will help eye strain due to computer vision syndrome. Let's take a look. A lot of us these days are spending more time in front of a computer screen or cell phone throughout the day, and when we spend this much time on a device that is only a few feet away from our face, it can cause muscle strain to our eyes. So, tip number one is to take frequent breaks. When you stare at a digital device for too long, your muscles will start to cramp up, and we call this as the accommodative spasm. To help relieve this, follow the 20-20-20 rule, which means that for every 20 minutes you spend in front of a device, take about 20 seconds rest and looking at 20 feet away in the distance, just so that you can give your eye muscles a bit of a rest. Adjusting your environment can also reduce the risk of developing computer vision syndrome. What you can do is adjust your screen position. And lastly, you can use your eyes to look at different direction and hold it for at least 5 seconds. You can start by looking outward and hold it for 5 seconds, and you can repeat it at a different direction, whether it can be downwards, repeat for 5 seconds, and looking sideways. Hope these tips and exercises are helpful for you to practice anytime and anywhere. Enjoy the rest of the event and stay safe!
Assalamualaikum and a very good morning to all honorable judges, professors, doctors, lecturers, and fellow friends. Welcome to the 11th UiTM Dental Student Scientific Symposium. Our theme this year is Dentistry Against All Odds, Revolutionizing Research and Practice. This e-poster presentation is streamed on our live telecast YouTube channel. Therefore, we would like to request all presenters and all symposium participants to fill in the attendance link on our website for this morning session. My name is Adlina Zulkifli and I will be your moderator for this morning poster presentation session, followed by Izzat Arif as our timekeeper. We are really honored today to have Associate Professor Dr. Aida Noor Ashikin Abdul Rahman from Faculty of Dentistry UiTM, Technologist Nur Hayati Muhammad Zain from Faculty of Dentistry UiTM, and Associate Professor Dr. Nur Intan Abdul Murad from Faculty of Dentistry University Malaya as our panel of judges for Magnolia 2. Before we begin, please allow me to lay down a few house rules for today's session. All presenters must be ready at least 10 minutes prior to your allocated presentation time. All presenters are required to use the provided virtual background on our website for the live Q&A session. The pre-recorded video presentation will be played by the committee for 10 minutes and subsequently followed by a 5-minute Q&A live session by the judges. For the presenters, please ensure your camera and microphone is only turned on only during this session. The first bell will be rang at the 4th minute of the Q&A session, and the second single bell will be rang at the 5th minute of the Q&A session, and the last multiple bell will be rang at the end of the session. After the Q&A session ends, the moderator will queue for the next presenter. In case of any technical difficulties or during the video presentation of the Q&A session, the other presenters must be ready on standby and should the allocated time be brought forward or earlier. Without further ado, let's start with the first recorded poster presentation from Anis Zafira binti Azman and Asila binti Rahimi with their research topic on epidemiology of non-odontogenic pain in UiTM Dental Center, a retrospective study. Assalamualaikum and a very good morning. I bid to the honorable judges, respected audiences, and my fellow colleagues. My name is Asila, and along with me this morning will be my partner, Anis Zafira, and we would like to present to you our elective research project entitled Epidemiology of Non-Odontogenic Pain, a Retrospective Study. We are honored to be under the supervision of an expertise in this field, Associate Professor Dr. Yoshinobu Shoji. Most patients come to the dentist with a complaint of pain, mainly in the orofacial region. And orofacial pain can be described as pain or dysfunction felt in the head and neck region, including the oral cavity. And it can further be divided into two types, from odontogenic origin and non-odontogenic origin. Odontogenic pain arises from the tooth itself, such as toothache due to pulpitis, dental hypersensitivity, etc. And non-odontogenic pain is derived from various structures of the head and neck, including musculoskeletal, neuropathic, neurovascular, sinusitis, and it can also be from cardiac or psychogenic origin. There is a vast range of clinical presentations for non-odontogenic pain. It can be from mild to severe pain, acute to chronic onset, intermittent to continuous, and it may disturb patients' quality of life. Although odontogenic pain is the most common type of orofacial pain, but non-odontogenic pain can also affect the head and neck region and may mimic dental pain. Our study is done to analyze the prevalence of patients that were diagnosed with non-odontogenic pain by the specialists at the Orofacial Pain Clinic of UiTM Dental Center. Moreover, we aim to classify the type of non-odontogenic pain from the most common to the least commonly diagnosed by the specialist, in addition to studying the correlation of the type of non-odontogenic pain with patient's age and gender. For methods, our study design is a retrospective study that we conducted from January of 2020 until March of 2021 at the Orofacial Pain Clinic of UiTM Dental Center in Sungai Buloh, Selangor. The criteria of patients included in our study are patients that were diagnosed with non-odontogenic pain by the specialist whose data are available in the dental center's dental record system called IDEMS, and they must be diagnosed in the span of 2016 until 2019. With that, the criteria of patients excluded from the study are patients that were not diagnosed with non-odontogenic pain and their data are not available in IDEMS, and if they were diagnosed before the year 2016 and after the year 2019. For sampling, we use a simple random sampling technique. The sample size was calculated using the EPI-Info version 1.4.3. We estimated the population to be at 200 patients, and the ideal sample size came up at 132 patients. Unfortunately, we only managed to achieve a sample size of 109 patients. The statistics were analyzed using the SPSS software version 25.0 with Pearson's chi-squared test. The retrieved data from items were then classified into age, gender, and their diagnosis. The calculation of this prevalence and incidence will hence determine the epidemiology and verify our objectives. Our results have proven that among 109 non-odontogenic patients, females make up the majority of the samples at 72.5%, while the remaining 27.5% are males. The mean age of these patients is 33.6 years old, and 40.7% of these patients are in the range of 21 to 30 years old. This pie chart in figure 1 shows the diagnostic classification of non-odontogenic pain, whereby musculoskeletal origin makes up the most commonly diagnosed non-odontogenic pain at 83%, followed by neuropathic at 7% and neurovascular and psychogenic at 5% each. No patients in this study were diagnosed with sinus or cardiac origin. This bar chart in figure 2 shows the gender distribution, whereby, as you can see, non-odontogenic pain has a stronger predilection towards female, no matter which type it is. And lastly, this bar chart in figure 3 shows the age distribution, whereby the most common age to be affected by non-odontogenic pain is in the range of 21 to 30 years old, except for in neuropathic origin, whereby the highest percentage is at the range of 51 to 60 years old. That's all from me. Thank you. Discussion and conclusion will be further discussed by my partner, Anis Zafira.
Thank you so much, Asmila. Assalamualaikum and good morning, to everyone. I will continue to the discussion part of our study. From the results, we can see that there is a large discrepancy between the number of male and female patients. This discrepancy might be explained by the role of gender norms and pain tolerance. Lipton in 1993 reported that females had twice the rate of TMJ pain compared to men. Another study by Poole in 2007 also supported this statement as a proof that both women and men believe that men should tolerate more pain than women. They also reported that men have been found to tolerate more pain under experimental settings, including pressure pain, cold pressure pain, thermal pain, and also electric shock pain. Our study also found that musculoskeletal origin is the highest diagnosed orofacial pain, specifically due to temporomandibular joint disorders. Schaeffer in 2018 reported that temporomandibular disorders are the most prevalent type of orofacial pain, affecting 5% to 12% of adults. Kraft in 2007 also reported that the onset of temporomandibular disorders are usually seen among women after puberty and decline postmenopausally. The second commonly diagnosed orofacial pain among UiTM dental centers patients is from neuropathic origin. Neuropathic pain is described as one of the most painful pain in the orofacial region. From our study, most of the patients diagnosed are women ranging from the age of 51 to 60 years old. Our findings correlate with a systematic review done by Di Toledo in 2016, which reported that neuropathic pain affects 0.03 to 0.3% of adults, ranging from the age of 37 to 67 years old. Orofacial pain from our study is from neurovascular origin, and most of them are women. 3 of the patients were in the age range of 21 to 30 years old, while 2 of them were around 41 to 50 years old. A study by Magnolia in 1997 on patients with vascular type features found that 70% of them are women, with average onset of 42.6 years old. Moving on, our study showed that psychogenic pain is the least diagnosed orofacial pain. Psychogenic pain is a disorder associated with psychological factors such as mental or emotional problems that cause the patients to present with pain that does not match their symptoms. From our study, only 6 out of 109 patients are diagnosed with psychogenic pain. 3 of them are under the age group of 21 to 30 years old, while 4 of them are female. Freeman in 1983 did a study among 93 patients and found that 54% of the patients were diagnosed with facial arthromyalgia, while the other 46% is diagnosed with atypical facial pain. They found that 60 of the patients were women. Last but not least, our study did not have patients diagnosed with cardiac origin. Cardiac origin facial pain is extremely rare. Sharifi in 2016 did a study and found that 0.6% of 215 patients with ischemic heart disease and angina pectoris reported of maxillofacial and chest pain. Another case study by Lopez in 2012 involving 30 patients who were doing cardiology found that only 11 of them complained of referred orofacial pain previously or during cardiac seizures. In conclusion, in our study involving 109 patients of UiTM Dental Center who came with non-odontogenic orofacial pain, we found that it mostly affected women as compared to men. It also commonly affects young adults in the age of 21 to 30 years old. And last but not least, we found that the patients are mostly diagnosed with musculoskeletal pain, followed by neuropathic, neurovascular, and psychogenic origin orofacial pain. We hope that our study can help other dental practitioners to correctly diagnose non-odontogenic orofacial pain among their patients. Thank you.
Thank you, presenters. Now, let's welcome the judges for the Q&A session.
Assalamualaikum, Miss Asila and Miss Anis. I think it was a very good presentation, although the pace was quite quick. Okay, I have one question. It seems that you opted, can you hear me?
Yes, of
All
course.
right, okay. It seems that you opted to do retrospective study, okay, for your project. Okay, I think in terms of the study design, it should be stated as or named as retrospective patient audit or patient's data or patient's chart audit, because you're looking at it's something like clinical audit. All right. Okay, something that you can look again lah in terms of study design. But while doing the study, what are the limitations of using this study design? The retrospective study and also the use of, clinical data that is already in the system. What are the limitations?
I feel like personally for me, the limitation is that the available data is our only source, so we can't really like refer to the specialists who diagnose the patients as to if they remember what happened to this patient, if this patient was truly diagnosed with non-autogenic pain, because some of the patients they don't have a clear diagnosis, they only rule out TMD disorders. So I feel like that is our limitation personally for me, because that is our only source and we can only go through as you said, the clinical audit of these patients on the items.
Okay, having said that, I mean, there are limitations of, in terms of the validity, right? And the reliability of the data. That's what you're trying to say, right? What
Yeah, I
about
feel like
uh, would it be possible to generalize your findings? My
I
questions
feel
are
like
very basic because I want you to understand the basic of study design.
I understand. I feel like generalizing our results, we would have to include a larger population of the study. I feel like if we include just
How can you include a larger population when I think you included all patients, right, who were referred to OM specialist clinic,
yes.
right? So there's no way that you can include more patients, right?
I thought
But
like maybe we could do outside of UiTM Data Center also.
all right, but then it depends on the study objectives, all right? Because now
Yeah.
your study objective is only on
Yeah, we're
UiTM
focusing
patients,
on
right?
UiTM,
Okay.
yeah.
Just one note lah before I give to Puan Yati. When writing abstract, try to use past tense, all right? Because you have already conducted the study, all right? Okay. Puan
Thank you
Yati.
so much, Prof.
Thank you, Prof.
Thank you, Associate Prof. Dr. Intan. So I'll take over for the question and answer. So well done, Anis and Asila. Really like your presentation. So anyway, my next question is, why do you think that this epidemiology study is important in the area of oral medicine?
I think that this study is important because non-odontogenic pain is usually misdiagnosed by general practitioners. So they do unnecessary treatment towards the patient. So if we can correctly diagnose that the pain that the patient is having is from non-odontogenic origin, maybe we can do less harm to the patient in terms of giving unnecessary treatments.
Okay. So what does this data leading to? So what are you going to use this data for?
I would probably use this data for diagnosing patients when they come with pain that that does not correlate with odontogenic pain.
So you will probably like do a guessing game there to see like the statistics. What are the probability of the patient's diagnosis? Is it?
Not
Another way.
exactly. For example, to diagnose musculoskeletal origin pain, we also have to do examinations and investigations first before we can fully come to the conclusion that it is an non-odontogenic pain.
Okay.
Sorry, doctor, if I may add, I feel like with this study, in terms of diagnosing patients, we can relate the data in terms that, let's say this patient is a female and this patient is in the range of, let's say, younger adults of 21 to 30 years old, as we have proven in our study. So we feel like if that patient came in with symptoms and with non-autogenic pain symptoms, I feel like it will be easier for us to diagnose the patients as the patient is a female and they are in the range of the younger adults. So that is how I feel like I would use our research data.
Do you think that the finding from our center is different than what can be found in other published data? Is it very population related on the epidemiological data from your discussion?
I feel generally with our study, mainly for the age, for the gender, and the main diagnosed non-orthogenic pain, I think it's quite similar to other studies that we have found.
Okay, so it's not really population related.
Yeah, I don't think so.
Okay. And when Yati, do you have any question?
Can I just add, what's your exclusion criteria again?
Our exclusion.
Because it's just the opposite of inclusion criteria, kan?
Yeah, that's
If you read it properly, right? You put A, B, and C, and then your exclusion criteria is like not A, not B, not C. Can't really do that lah in research.
Okay.
You have to spell the exclusion and inclusion criteria really well. Okay, have to distinguish
Yeah,
between each other. All right. Okay.
Thank you so much, Prof. Thank you so much for the feedback.
Okay, thank you, Prof.
Okay. Belum 5 minit lagi.
Thank you, judges and presenters. Sorry, because due to the time constraint, we have to continue for the next presenter. But before that, we would like to present the next for the presenters for the certificates for their for your participation.
Okay, thank you.
Okay, let's move on to the second e-poster presentation by Alia Farha and Sophia Dini with their topic of effect of probiotic-based functional food on dental enamel, a systematic review.
Assalamualaikum, my name is Alia Farha and along with me is Sophia Dini. We will be presenting a poster presentation on our ERP project entitled Effects of Probiotic Containing Functional Foods on Dental Enamel Structure, a Systematic Review. I will start with the introduction, methods and results. On the other hand, my friend Sophia will present the discussion, strengths, limitations, and our conclusion that we came across. Ladies and gentlemen, allow me to introduce to the scope and aim of our review. As we all know, dental caries is a worldwide oral health problem which is defined simply as a localized breakdown of vulnerable dental health tissues. There are many factors that contribute to dental caries, including host, substrate, bacteria, and time. In order to combat dental caries, WHO has recommended several practices in order to help prevent dental caries, such as the use of fluoride, better oral hygiene procedures, and proper dietary practices. Focusing on dietary practices, functional food worldwide plays an important role in promoting oral health, as their aim is to provide additional benefits beyond basic nutrition. Functional food is defined as enriched food that have a positive impact on the human body. Currently, functional food market is dominated by symbiotic, prebiotic, probiotics, fatty acids, dietary fibers, carotenoids, vitamins, and minerals. Functional dairy products accounts for more than 40% of the functional food market. Probiotic enhanced dairy product is a subset of the functional food domain and is what this review is focused on. Probiotics is defined as a live microbiome food supplement that when taken in adequate amount aims to exert health benefits on the host. Lactobacillus and Bifidobacterium are the most common genera utilized as strains in these food products, as they are mainly used for their proven gastrointestinal health benefits. However, their documented benefits toward oral health is limited. This in an attempt to understand the role of probiotic-containing functional food in oral health, specifically their role in influencing enamel structure. The aim of this evidence-based analysis is to look at the original research papers that investigate the effects of commercially available probiotic-containing functional food on dental enamel structure. Moving to the methodology, in order to do this, we choose a set of keywords that our literature search will be based on. We choose keyword number 1, probiotic, number 2, enamel, or demineralization or remineralization. As we wanted to look at recent studies, we narrowed our findings to the last 2 decades, starting from the year 2000 until 2020. We chose 2 databases, Magnolia and Sentinel, as we wanted the studies to be half related. The main inclusion criteria were number 1, published in English. Second, studies use commercially available probiotic-containing functional food. And number 3, studies had to report on the association of probiotic-containing functional food on dental enamel structure. Our exclusion criteria were studies that number 1, isolating a specific probiotic strain and not studying the effects on enamel structure. Number 2, reviews, news, letters, editorials, and case studies. And number 3, animal studies. This flow chart shows the steps we conducted in order to eliminate irrelevant articles. As for the results, our initial search gives us 642 studies from both databases. After going through the articles based on the inclusion and exclusion criteria, excluding duplicates, we were left with 9 articles. We then tabulate the key findings from the 9 articles as shown in Table 1 here. So, our review consists of 3 studies using bovine dental enamel blocks, while 6 studies using human permanent or deciduous teeth. 2 of the studies using human teeth were conducted in vivo, while 4 studies were conducted in vitro. Out of 9 studies, only 1 study did not use dairy products as the mode for probiotic delivery. However, the other 8 studies used commercially available dairy-based probiotic products such as milk and yogurt as their functional food of choice.
Thank you, Alia, for explaining regarding our introduction, methods, and result. As the aim for our review, we wanted to look into the effect of commercially available probiotic functional foods on dental enamel. We specifically focus on the enamel structure changes, which is mineral loss. Overall, from the selected 9 articles, what we found were mixed findings. There were both positive and also negative findings with regards to the enamel structural changes. There was a strong evidence of benefits of the probiotic functional foods on enamel, as 56% of the reviewed article has positive changes in minimizing the mineral loss on dental enamel. Lori et al. In his study found that treatment with Bata-V2 fermented milk had a significant lower percentage change in enamel surface microhardness in comparison with treatment with Yakult and control group. The Bata-V2, a fermented milk, contains 3 probiotic bacteria, has seemed to yield better than Yakult, which only contains a single strain probiotic. This is because application of different probiotic bacteria affects the balance of the oral ecosystem via possible additive, cumulative, and competitive modes of action. However, there are 2 papers, Ali et al. And Shan et al., which reported negative findings, while 2 papers reported no significant effects. According to Ali et al., probiotic containing milk formula had the highest degree of demerization due to the presence of 2 bacterial species in caries development through multiple mechanisms such as acid production and resistant to acidic exposure. The 2 lactic acid presented in the formula milk was Bifidobacterium and Lactobacillus. One of the most important characteristics leading to their carcinogenicity was the acid byproduct of carbohydrate fermentation. Shan et al., on the other hand, discovered that commercial yogurt containing live probiotic culture further reduced the enamel mineral content by 320% than the initial lesion due to the presence of added sugar string, which will later promote carriers to take place. The yogurt contains very high lactic acid concentration, which inhibits the buffering of the artificial saliva and created an acidic environment. Based on the issues above, the main issue regarding the effects of commercial probiotic drinks on towards human body is that it is a double-edged sword, as we can see from the bottom left poster. Even though the probiotic have a positive effect and provide beneficial bacteria for the gastrointestinal environment and can prevent and compete with harmful oral microflora, there are two factors that can negate this therapeutic effect. The two factors are the high sugar content in the beverages itself and the acidic nature of the probiotic bacteria. According to our literature search, this is the first systematic review on commercially available functional food products and their impact on dental enamel structural changes. Our analysis included the most recent published article in our area of focus, covered both in vivo and in vitro study, as well as providing a hypothesis on why we saw mixed findings regarding this matter. This study has limitation. Several studies fail to distinguish the probiotic bacteria strain used in each of the probiotic functional food products studied. Other criteria such as pH, buffer, blood count were also included in most and many of the articles, thus making the analysis on its effect on dental enamel were not standardized among all the studies. Apart from that, several studies were conducted using the bovine dental enamel blocks. In conclusion, further studies are needed to determine the ideal properties of probiotic functional food products, such as having low capacity of acid production. The probiotic strain with antimicrobial property, pH buffering effect, and less acidogenic would be ideal for the general public. That's all from us. Thank you.
Thank you, presenters. Now we would like to invite the judges for the Q&A session.
Assalamualaikum, Alia and Sophia Dini. Can you hear me?
Yes, okay.
Okay, thank you for the presentation. I have two questions. The first one, I saw that in your study, some of the study included were actually RCT study, randomized control trial, because it involved the patient, right? Because some of the studies are on patient. Okay, so for that RCT study, did you apply any scoring system to assess the quality of that study before you include it in your articles, selected articles? Any scoring system?
No, but we
So mean you just based on your
not include any. It's just based on the inclusion criteria.
okay, so you just based on your exclusion criteria, is it? Okay, it's okay. Okay, my second question, okay, based on the conclusions, you stated that mixed finding where further studies are required to identify the ideal property of probiotic containing functional foods. And on the poster, you listed the cons part, okay, where it have high sucrose, acidic nature, where for the oral part is only it going to intervene with the bad bacteria. Only one out of two for your cons part. So if you want to further this study,
what will be your next approach? Okay, because you see that, yeah, what will be your next approach? Are you going to change your keywords, or are you going to look on what type of probiotic? What will be your approach for your future study? If you have chances to do another review that related to probiotic functional food.
Maybe in the future we can include the studies that have that since the cons in this study is that the addition of the glucose and also the medium of the
Hello, sorry.
of
Anya.
the probiotic containing and also with a better. Okay, Ella, Doctor, can you hear me?
Hello, okay, Alia.
Can you
Yeah,
hear me?
yeah. Yeah, just now there's some problem. Can you continue, Alia? Can you repeat your answer? Or maybe Sophia Dini, you want to help? Because I think Alia have a connection problem.
In our future studies, since from the limitation, some of the studies didn't mention the probiotic strain that they use. So in future study, we wanted to select studies that mention strain that were used, and the one study that only focus on the enamel demineralization, effect on enamel microhardness.
Okay, thank you. That's all from me.
Thank you, Panyaki. Thank you very much, Sophia, and who is the other presenter? Alia Farha. Okay, thank you very much for your presentation, and well done on carrying out the systematic review. It's not an easy task, I bet. My two question here is, what are the keywords you use in your search?
Okay, the keywords that we use in our search is number one, probiotic star, and second is enamel or demineralization or remineralization.
Okay, and do you use the mesh format?
No.
No, you did not use that one. Okay, and why do you choose Medline and Sinal search engine?
Because we want our studies to be medically health related studies. So which is Medline and Sina. And the second one is because it is easily accessible compared to Scopus. It needs a subscription, yes. So we can access Scopus, so we proceed with Sina and Medline.
So do you think that your study is comprehensive because you might miss the papers in Scopus, or you think you can accept this conclusion of your studies as a final conclusion?
No, the studies, I think it is. Since we didn't include much database, so in the next study we wanted to use more data.
You expect more publication in another database?
Yes.
Okay.
So sorry, doctors. Sorry, judges and presenters. Your time is up. So thank you.
Okay,
Thank you all.
Okay.
Before we move on to the next presentation, we would like to present the e-certificates for the presenters for your participation in this symposium. Now let's move on to the third e-poster presentation by Nordini Fadrina binti Masri and Nur Shamiza Idayu binti Hassan with their research topic of antimicrobial activities of Labicia pumila, a systematic review.
and good morning. My name is Dini Fajrina, along with my friend Noshamiza Idayu from Faculty of Dentistry, UiTM Sungai. Today, I would like to present a systematic review entitled Antimicrobial Activities of Labicia pumila. The presentation outline consists of introduction, objective, methodology, results, discussion, and conclusion. Firstly, we will look at the introduction first so that we will have ideas on how the systematic review is all about. Labicia pumila, LP, or locally known as Kasih Fatimah, is the queen of herbs in Malaysia with various traditional uses. The most common three varieties of LP found in Malaysia are Va'alata, Va pumila, and Va lanceolata. The herb was proven to have bioactive compounds like saponin, phenolates, flavonoids, fatty acid, and phytoestrogen, which are responsible for its antimicrobial, antioxidant, anti-inflammatory, anti-aging, anti-carcinogenic, and estrogenic effects. Next, we will look at the objectives. This study aims to provide a systematic review of antimicrobial activities of Labicia pumila. For the methodology, a comprehensive search was conducted using Scopus and Medline via EPSC cohorts with specific keywords for related studies published between January 2000 until December 2020. The main inclusion criteria were research articles published in English and studies reported the effects of Labicia pumila on microorganisms. Meanwhile, the current study excluded review articles, news, letters, editorials, or case studies. Papers were screened in 3 phases before chosen for the systematic review as shown in Figure 1. As you can see, in the first phase, the papers were identified by using Medline and Scopus. In the second phase, abstract of the remaining papers were screened to meet our inclusion criteria and duplicates were removed. And in the final phase, text of the remaining papers were read thoroughly to exclude any paper that did not meet our inclusion criteria. The papers were then screened by all authors for the final selection before approving them for the data extraction phase. Next, data extraction were performed independently with the use of a data collection form to standardize the data collected from each study. The following data were recorded from the studies, which are the first one is the types of Labicia pumila extract from the studies. The second one is a brief description of the method used in the study. And the third one is a brief description of the result of the study. And the final one is the comments and the conclusion of the study. Next, Noshamiza Idayu will continue.
Okay, I am Noshamiza Idayu and I will continue with the result part. We found 5 identified studies that met the inclusion criteria and all were in vitro studies published between 2011 until 2015. The 5 papers that were included in our review are papers from Ehsan Karimi et al. 2011, 2013, and 2015. From Mansur Fazliana et al. 2011 and from Nazmul et al. 2011. For Labicia pumila extract, all study done by Ehsan Karimi used all 3 varieties of Labicia pumila, which are Va pumila, Va'alata, and Va lanceolata. And then study by Nazmul didn't mention the specific variety, while study from Mansur Fazliana used Va'alata species. Okay, also for Labicia pumila extract, study done by Ehsan Karimi et al. 2011 and Nazmul et al. 2011. They used crude extract of Labicia pumila. Meanwhile, study by Ehsan Karimi et al. 2013 and 2015 used microwave-assisted extraction. Last one, study by Mansur Fazliana et al. 2011 used standardized water extract for Labicia pumila extract. Okay, moving on to methodology. Study done by Ehsan Karimi et al. 2011 do analyze the content of phenolic, flavonoid, and saponin. And then the antibacterial assay was done using distribution method, while study for antifungal assay was done using agar-well diffusion method. The next study by Ehsan Karimi et al. In 2015 used agar-well diffusion method for antifungal assay, and in 2015 Ehsan Karimi et al. Used this diffusion method for antibacterial assay. And then study by Mansur Fazlana et al. 2011 used agar diffusion sensitivity assay for antimicrobial activity test. There are also infection assays done, which are adherence assay and invasion assay, to assess for Labicia pumila alata effect on urinary tract infection. And then the study by Nazmul et al. 2011 used standard disk diffusion method for antifungal assay. Okay, for the result, study by Ehsan Karimi et al. 2011 proved that the leaf bud contained the highest saponin levels than root and stem in all three varieties. And then for antimicrobial activities, Labicia pumila pumila had the highest antibacterial activity against gram-net positive bacteria, while Labicia pumila alata had highest activity against gram-negative bacteria. Meanwhile, the leaf bud of Labicia pumila alata proved the highest activity against the fungal tested. Next study by Mansur Fazlana et al. 2011 only proved a distinct zone of inhibition against Staphylococcus aureus. It was highlighted that there is a significant reduction in the number of intracellular bacteria in Labicia pumila alata treated T24 cells if compared to non-treated control cells. However, it did not affect the bacterial adherence to T24 bladder epithelial cells. Okay, next study by Nazmul et al. 2011 showed no ability to stop the Candida albicans and the presented of low antifungal activity against the fungal tested. Moving on to the next study by Ehsan Karimi et al. 2013, it shows positive results as the leaf exhibit higher activity towards the tested fungi at concentration of 450 microgram per well in all three varieties. Okay, and last but not least, for the result, further study by Ehsan Karimi et al. In 2015 showed low inhibition if compared to kanamycin. To be specific, it was concluded that Labicia pumila lanceolata had lowest inhibition against bacteria if compared to Va pumila and Va alata. And then the gram-negative bacteria were found to be less sensitive against the extract if compared to gram-positive bacteria. Okay, as for the discussion, bioactive compounds such as flavonoids, saponin, and fatty acids are responsible for antimicrobial activities of Labicia pumila. And then, based on 5 studies, it can be concluded that different plant parts exhibit different results, with the leaf show the best antimicrobial activity due to higher content of important compound. And then, geographical factors such as climate and soil condition might influence the efficacy of Labicia pumila medicinal activity due to different composition of bioactive compound. That is why study by Ehsan Karimi in 2011, 2013 and 2015 raised Labicia pumila under similar glasshouse condition for 18 months regardless of their different origin. This was also the reason of failure in Nazmul's study to stop the growth of Candida species by Labicia pumila, whereas Ehsan Karimi reported Labicia pumila had highest activity against the Candida species. Okay, for the conclusion, Labicia pumila antimicrobial activities was proven to be mild to moderate against certain microorganisms. So, further studies are required to determine the molecular mechanism and its specific action as an antimicrobial agent before clinical studies are conducted and being commercialized. And as for example, in dentistry, it has potential to be commercialized as the mouthwash to treat oral cancer.
Thank you, presenters. Now let's welcome the judges for the Q&A session.
Okay, Assalamualaikum, Miss Dini and Idayu. Betul, I'm looking at the correct one. Okay, yeah. All right. Okay, I think that was a very good study because you focus on Kashif Fatima. I think it's quite novel. Just that you did a systematic review. May I know how did you formulate your research question? Did you use any tools to formulate your research question or your search strategy? Boleh dengar because I can't hear and I can't hear you.
Yeah.
Okay, sebab diam je. But Idayu, am I the only person yang ada problem Wi-Fi?
Saya tak dengar juga. Nasha Mirza, we cannot hear you.
We can't hear Idayu. Maybe Dini can help? Dini
Assalamualaikum. So for the question, how do
how did you formulate your research question? Did you use any tools? Because this is you said because you are doing systematic reviews kan? There are some steps that you have to follow. I think I lost these two girls.
Actually, before this, we have preliminary study for the for the antimicrobial before this actually there have been systematic review for the properties of Kashif Fatima, which are anti-inflammatory and also antioxidant. Hence we plan to do research for to find out whether Kashif Fatima can give effect for the antimicrobial properties.
Betul. Did you use any, because if you look at systematic reviews, the steps to do systematic reviews, there are certain steps that you have to follow. Okay, some researchers, they use the PICO tools. Some researchers, they use the spider tools. Okay, there are some tools. Because if you say you're doing systematic reviews, kita kena follow lah some, some steps, evidence guide steps, So did you use any PICO tools?
Okay.
Ada ke tak?
We use research question and keywords.
Okay.
Boolean operator.
Apa dia? What are the keywords?
What are the keywords?
No, I mean how did you derive the keywords and how did you derive your research question? You tak use any tools lah. That means it is based on what your study objective, yeah? Betul ya?
Based on objective and also based on the keywords.
Alright, okay. Nanti you tengok balik steps to do systematic review. Okay. Okay. Who actually who were involved in critically appraising the studies? Because I think you have eliminated quite a lot of study. Betul kan? In the end, you only included 6. Right. Who were involved in critically appraising all the papers that you have compiled? Siapa yang involved? Siapa yang really look at the studies, whether this one should be included, this one should be excluded? Who were involved?
I think three reviewers involved.
Okay, siapa ya? Including you lah, yeah?
It based on the figure. It based on the figure as shown in the poster.
Alright, tapi I can't remember that. Can you just tell me, are they the experts in this area? Because kalau you tengok juga systematic reviews, they must at least be an expert lah. They must be familiar with the topic. So actually kan, Dini and Idayu, you must be able to distinguish between systematic review and literature review. So you reflect back whether you are doing systematic review or literature review, okay? Alright?
Okay.
Alright, okay. I pass over to, I think, Puan Yati,
Thank you, Dr. Intan. So, Assalamualaikum Dini and Idayu. Can you hear me? Boleh dengar?
Yes. Salam,
Okay.
yes.
I just have one question regarding the poster because I saw on the poster after you do the data extraction, you mentioned that article excluded without abstracts. What do you mean article excluded without abstracts? Does that mean you download the full article but no abstract, or it's supposed to be abstract only article? In your methodology, I'm referring to your poster.
Okay. For there's meaning abstract does not focus on our keyword. Does not focus on
Oh,
file activity.
okay. So you are not supposed to write without abstract, okay? Because it have the abstract over there, right? You are not supposed to write without abstract because I'm quite wonder how the article without abstract. Okay, it's okay. So when you assess the scopus and also the Medline, did you use our library databases where you can
Yes.
actually, yes. So you assess it through using the easy access
Yes.
from
Easy
our
access
library.
library. Yes. Yes.
Okay, so you able to extract the full article, right? Okay. Um, do I have still time? Masih ada masa ke? Okay. Okay. So what will be your future recommendation for this study? If you want to, you said you want to uh bring it maybe for the clinical setting. So is it uh, any design or any specific things that you would like to apply in clinical setting? Maybe for example, the type of abstract. What type of abstract that you found have the best activity based on your study? Type
Based on
of
our
abstract, is
study,
it aqueous abstract? Is it?
we do use different extract. For example, study by Ehsan met all you use something for extract. So it might show
To
the different
extract.
result. And then
So you said okay.
for clinical studies, maybe we can use antimicrobial properties of Labicia formula to use to treat denture stomatitis, which commonly caused by Candida species.
Okay, that you find the good activities again, Candida, just now from your study? Sorry if I missed that, because I see most of it is only the bacteria, the E. coli. Did you find the good activities against Candida albicans also? Ada ke?
Yes.
Yeah.
Arimi.
Okay. One study.
But
Okay.
low inhibition.
Low inhibition. Okay. Okay, I think that's all from me. Thank you.
Prof. Aida, tak ada question Okay. And also, I just want to add, when you are giving conclusion for the systematic review, you must also include the quality of studies. That okay. Okay.
Actually, for the question how
Sorry.
we formulate the question, how do we
Sorry.
okay.
Sorry, we have to stop for now. Thank you, presenters and judges. Now we would like to present the e-certificates for the participants for your contribution in this symposium.
Nabila, we cannot hear the bell, yeah?
Now
Nabila,
let's move on. Yes.
dia tak dengar bell. Okay.
Okay. Okay. Doctor. And now let's move on to the fourth e-poster presentation. Please welcome Shahira binti Ahmad Azina and Nurul Fahanis binti A. Aziz, who will be presenting on the correlation between stress perception and psychological changes among UiTM clinical undergraduate dental students.
Assalamualaikum warahmatullahi wabarakatuh and good morning I bid to the panel of judges. My name is Farhanis and together with me is my partner Shahira. We are here on this beautiful day to present our research elective project titled The Correlation Between Stress Perception and Physiological Changes Among UiTM's Clinical Undergraduate Dental Students. Mental health problems are no longer an obscurity issue in Malaysia. According to the National Health and Mobility Survey in 2015, every 3 in 10 Malaysian adults aged 16 and above suffered from mental health issue. Sharma 2018 and Jena in 2016 had found out that long-term stress is one of the culprits to this illness. One of the potential stressors that has long been identified is an occupational stressor. Malaysian Journal of Public Health Medicine in 2018 showed that up to 70% of Malaysian workers being reported for having occupational stress, which include dentists. High level of stress among dental practitioners appears to begin during dental school, and it is manifested differently during different years of studies. A research by Butler et al. In 2015 had found out that dental students were prone to get stressed as dental education has long been recognized as a complex and highly demanding training. However, up to date, most studies were just assessing stress through questionnaire that were merely based on the perception of the respondent, which is very subjective as it is influenced by the personal characteristic of an individual, which has been discovered by Bill et al. In 2016. As stress is also able to cause a number of physiological changes such as increase in heart rate, blood pressure, blood glucose level as well as decrease in oxygen saturation. Therefore, assessing both the perception of stress and the physiological changes in our study might provide more objective evidence about the individual actual stress condition to avoid chronic stress, which is one of the causes of mental health illness. Hence, the objective of this research is to observe the correlation between the stress perception and the physiological changes among UiTM's clinical undergraduate dental students. Proceed with the methodology. A total of 49 clinical UiTM undergraduate dental students were selected for this study using a randomized stratified sampling technique. Undergraduate students that are currently on medications such as psychotic drugs or drugs that can stimulate or inhibit the nervous system or have any medical or mental illnesses are excluded from the study to avoid bias. The participants were surveyed using a perceived stress scale questionnaire, which is a widely used psychological instrument for measuring the perception of stress. As for the measurement for the physiological changes, the participant blood pressure, heart rate, oxygen saturation were measured using a dynamic cascade vital sign monitor, whereas the fasting blood glucose level was measured using a glucose meter. This research was conducted during 2 different periods, phase 1 which is in clinical week and phase 2 which is in exam week. The questionnaire form of the perceived stress scale was distributed via a Google form link, and then the participants were called to collect the data in the morning for the physiological measurements. All the responses for the Google form and the measurement reading were analyzed using a GraphPad Prism Scientific 2D graphic and statistics software for Windows. Paired t-test was done to analyze the significant difference between the 2 phases for heart rate, blood glucose, oxygen saturation, systole, diastole, and stress perception. The strength of correlation between the total score of stress perception and the physiological changes measurement were analyzed using a Pearson correlation analysis. For the demographic of the respondent, all of the 49 respondents are from UiTM's clinical undergraduate dental students. The pie chart shows that the majority of the respondents were female, which is 86%, followed by male respondents, 14% between the age of 22 and 25. As for the result of this research, from the bar graph that demonstrate the mean reading of the stress scale and the 5 physiological parameters during phase 1 and phase 2, it shows that there is no significant difference between the heart rate, oxygen saturation, systole, diastole, and fasting blood glucose. However, there was a significant difference between the stress scale with the value of P less than 0.05.
Assalamualaikum and a very good morning everyone. My name is Shahira and I will continue to present our result in observing the correlation between stress perception and physiological changes parameters. So generally in phase 1, as we can see in the first table, this study found that there is no significant correlation in between stress scale and 5 physiological changes parameters with value of R all are less than 0.3. However, between systole and diastole, there is moderate correlation with value of R equal to 0.54. Also, moderate correlation can be seen between diastole and glucose with value of R equal to 0.46. Moving to phase 2, as you can see in the second table, the result also led to similar finding where there is also no significant correlation between stress scale and 5 physiological changes parameters with value of R all are less than 0.3. On the other hand, between the parameters systole and diastole, there is moderate correlation with value of R equal to 0.49. Moving to discussion, as has been stated in the results, in comparing between the two phases, all the physiological changes parameters measured show no significant difference, with p-value more than 0.05 between clinical week and exam week. Even though the stress scale shows a significant difference with the p-value less than 0.05 between the two phases, with a mean score of 18 in clinical week and 20 in exam weeks, but both of them are still categorized under the same stress level, which is moderate according to the perceived stress scale. So these findings are somehow contradict the hypothesis as this current study speculates that students will show higher stress in exam week compared to clinical week. Nonetheless, this current study believes that it is well justified as there are changes in UiTM's BDS academic calendar due to the MCO in response to the global pandemic of COVID-19. These changes lead to a less stressed environment for the students compared to their regular academic calendar. Students were having ample time to do the exam preparation at home with no pressure of completing the clinical requirements and less stress at home. Next, moving to the correlation between stress perception and physiological changes. Contrary to the previous study, our results demonstrate that there is no significant correlation between the stress scale and the physiological changes parameters in both clinical and exam weeks. So this study speculated that this result might be due to the homeostatic mechanisms. According to Betts et al., homeostasis is the state of steady internal, physical, and chemical condition maintained by living systems. Adaptive homeostasis enables biological systems to make a continuous adjustment for optimal functioning, which is also known as negative feedback. However, according to Pometu et al., this adaptive homeostasis declines with age. Aging is associated with the inability to activate and modulate several adaptive responses. So since all of the participants in this study are young adults between the age of 22 to 25, they were able to respond well to the external stresses by this adaptive homeostasis. Furthermore, a study by Thompson et al. Reported that dental students appeared to cope better with stress compared to medical students. So this coping mechanism can help in preventing the unwanted impacts of the stressful situation on the physical and also health maintenance, including mental health. So as for conclusion, the finding of this study showed that there is no significant correlation between stress perception and heart rate, oxygen saturation, systole, diastole, and fasting blood glucose among young adults of UiTM clinical undergraduate dental students during this amended academic calendar due to the pandemic COVID-19. So this suggested that UiTM's clinical students were well adapted with stress as their stress level at both phases presented with moderate stress with no significant physiological changes were observed. However, the correlation can be investigated further during the regular academic calendar and also on middle-aged and older adults, such as dental staff, as aging is associated with more significant physiological changes. With that, thank you.
Thank you, presenters. Now we would like to invite the judges for the Q&A session.
Assalamualaikum to our presenter, Fahanis and Shahira. Well done on your presentation. I would like to ask you a couple of questions. Number one, the sample size. you mentioned that in your studies, 49 students, clinical students are involved in answering the survey. How do you derive to this number? Is it because the 49 only responded, or you only approached the 49 students?
Waalaikumsalam. So thank you for the question. We selected 30% out of all the total number of the clinical UiTM dental student. So that's where the 49, we approached the 49 student randomly based on the list name of the clinical student.
Okay. What is the full sample population of the clinical UiTM student?
76, which is include year 4 and year 5. Initially, we want to include year 3 as well, but due to the MCO, year 3 does not have any clinical experience yet, so we only included year 4 and year 5.
Okay, so when you say about clinical years, we assume that it's involving also year 3, so your sample is a bit small. But you need to actually clarify here, you only included year 4 and year 5, so that the assumption of clinical years and having your sample less than 60% respondent is not doesn't arise. Okay, another thing is I see that you've made a few hypotheses. Number one, for example, in your discussion, you said that dental students appeared to cope better with stress than medical students. Is that evidence, or is it by assumption?
That's based on our research, no, that from the previous research from an articles, evidence based.
Okay, so it is from published data.
Yes.
So, and do you find that your finding is also coincide with the previous published data? Because you're not comparing, so you're not sure.
Yeah, we're not comparing with the medical students, so we cannot say it's coincide with the studies.
Okay, but that is just a statement. Okay. How about the conclusion? You also stated that aging correlated or associated with physiological changes. And if you know that aging actually correlated with that, so by right, in other way, you know that the students are in the prime age, young students. So you already know that there's no association in physiological changes. Is that right?
Actually,
Is that understanding?
Yes, but the physiological changes, the age related is not the only reason. It's not the only affected in this study. It's also due to the MCO. So we expect that in further study, if we do in a regular normal calendar academic, so maybe the participant will shows more correlation between the stress perception and physiological changes. Because due to in this study, we due to the changes in the academic calendar, so there is less stress environment for the student, as less clinical experience the student have.
So anyway, good to know that the mandate timetable doesn't cause more stress. I'll pass the question answer platform to Sushi Dr. Intan. Is it pointed?
Okay. Okay, thank you, Dr. Aida. Assalamualaikum, Nurul Fahanis and Shahira. Yeah, thank you. You did a good presentation. And I have my first question. Do you have any inclusion criteria or exclusion criteria for your respondent? When you when you approach the students, do you have inclusion or exclusion criteria? Because you're going to measure the physiological variable. So do you have that criteria? So did you ask the student if he or she have asthma, any underlying condition before you approach them? Or you
Yes.
just give them the survey form?
We have exclusion criteria. The first one is correct the participant that are currently on medication. because it can affect their sympathetic nervous system, so it will give us the different result, or have any history of medical or mental illness. So we already exclude.
So you already exclude. So this 49 meets your exclusion criteria. Okay. Second question, how about the type of sampling? You mentioned you did a random stratified sampling. So can you explain to me what means by stratified? How you, because you have 2 years, right? 2 years of study. So did you choose 30 from year 4, 30 from year 5, or how you do that? How you did that? How you do your sampling?
The 49 students are certified according to the ratio of female and male.
Oh, okay. So you group them according male and female, not according to the year. Sorry, I can't hear you. Siapa yang cakap ni? Syahira, ya.
Certified are the subjects according to female and male. But for the study, we are not comparing.
Sorry, Syahira, I can't hear you. Maybe Fahanis can help.
We divide the participant for female and male not based on their clinical years.
Okay, so you, but how you get 49 is quite the odd numbers. So 49
30% from the male, since the clinical year only have male numbers smaller as compared to female.
Okay.
So we take 30% from the male and 30% from the female clinical student.
Oh, so how many out of 49? How many male? Out of 49, how many male? Or this 49 for male and 49 another 49 for female?
No, 9 from male, and then 66 from female.
66.
No, 9 from male and the rest are from female.
40. The rest should be
40.
40. Okay. Okay. So based on conclusion, you said that for this range means for the undergraduate, no correlation between the stress perception and also physiological changes. So what will be your next target if you plan to further this study?
Actually, our next target is to more focus on middle age or older age participants, such as dental staff, as older age shows more prone physiological changes. So we might see the correlation between stress perception and the physiological changes.
But why dental staff, not the PG student? Because you said you want to focus on the exam and all that, kan? I
Yes.
think maybe you can include the PG student, because normally they are out of the age is not in this range. Okay, thank you. That's all from me.
Any question from Prof. Norintan?
I think masa dah lama dah habis.
Tapi tadi baru je Izzat kata 2 minit. Okay, but anyway, thank you.
Thank you, judges and presenters. Before we move on to the next presentation, we would like to present the certificates for the presenters for your contribution in this symposium. Moving on to the 5th E poster presentation, please welcome Nur Shahira binti Ahmad and Nur Shahira binti Nasmi with their research topic of perceived clinical competency level of students and patient satisfaction of inferior alveolar nerve block performed by dental undergraduates.
Am I ready to inject a patient? How will the patient feel? Will they be in pain? Or actually, Do I qualify to do this procedure? That's the question. So, Assalamualaikum warahmatullahi wabarakatuh and a very good morning to judges, friends and audience. I'm Nur Shahir binti Ahmad and along with me today is my partner, Nur Shahir binti Nazmi. We are going to present on our research title, Perceived Clinical Competency Level of Students and Patient Satisfaction of Inferior Alveolar Nerve Block performed by dental undergraduates. Stepping into clinical years, we are eager to do and practice every single thing, every single knowledge that we have learned. But at times, nerve get to us. Most especially during this pandemic and lockdown, we have a very limited preclinical training before start to treat our patients, human beings. So here in our study, it was conducted to unravel an innovative clinical simulator prior to students performing local anesthesia on their patient. And our aim here is that we want to construct and validate a self-reflective questionnaire regarding the students' perceived competency level in performing inferior alveolar nerve block and also to assess the patient satisfaction in receiving the inferior alveolar nerve block performed by the dental students. Result obtained from our study, it signifies that with the aid of local anesthesia simulator kit, also known as LAS, it is more effective in students' training of local anesthesia. This further reflected in their first time performing IMB based on the patient's feedback in the UiTM Satisfaction Dental Local Anesthesia Scale, also known as USDLS. Here in our study, it consists of 40 third-year dental undergraduates and 40 patients. Then, they were randomly assigned into two groups, either interventional or control group, and each group consists of 20 participants. This cross-sectional study was conducted at Faculty of Dentistry UiTM Sungai Buloh, and along this study, two survey questionnaires specifically for the students and for the patient were used as a method of data collection, which each questionnaire consists of 4 questions of demographic characteristics and 20 questions of 5 Likert scale statement.
Thank you, Shahira. Now I'm taking over this presentation. Upon questionnaire construction, which is phase 1 of our research, both questionnaires had undergone similar steps. Our first questionnaire, which is questionnaire A, targets the student's perceived clinical competency in performing inferior alveolar nerve block with major domains touching the perceived confidence, knowledge, and also attitude to perform the task. Questionnaire B, which is the USD-LAS UiTM Satisfaction of Dental Local Anesthesia Scale, was drafted based on the American Customer Satisfaction Index model and also Iowa Satisfaction with Anesthesia Scale. We had illustrated this flowchart of our research activities in phase 1 and phase 2 for both questionnaires. I will first explain on questionnaire A. Questionnaire A had undergone content validation by 8 oromaxillofacial surgeons, followed by 1 neurosurgeon, 2 health informatic experts, and also 1 biostatistician. Questionnaire A was then amended according to the experts' feedback and used in phase validation by 82 first-year dental students, sessions 2019-2020. Results obtained from the phase validation were used to improve questionnaire A so that it will be on a suitable level for subjects to answer in phase 2 of our research. A pilot study was conducted among 73 third-year dental students, session 2019-2020. The validated questionnaire A was then used in phase 2 of our research. In our actual study, the study population comprises of 40 third-year dental students, which were then divided into 2 groups, interventional and control group via convenience sampling. Then, we distributed the questionnaires within both groups before and after they performed their first inferior alveolar nerve block. Construction of questionnaire B followed similar steps as per questionnaire A. However, phase validation was done by 40 third-year dental students, session 2020-2021. Construct validation will be performed in the future study which will be conducted in May. Now, for the results of our research, as you can see here, the first graph on the left shows that students in the interventional group showed a higher overall positive feedback after being introduced to the local anesthesia simulation kit. The graph on the right shows the patient's satisfaction and feedback towards the inferior alveolar nerve bulb received were positive. Cronbach's alpha coefficient were used to analyze the internal consistencies for both questionnaires. In regards for our discussion, we believe that the validation of questionnaire A will provide a reliable measuring tool to gauge awareness of preparedness and perceived confidence of dental undergraduates in performing regional anesthesia, namely inferior alveolar nerve bulb. For the USD last questionnaire, domains pertaining patients' perception towards the operator and also their satisfaction towards the inferior alveolar nerve bulb received were positive throughout the study. We hope that USD last questionnaire will be further validated in future studies as patients' satisfaction and feedback greatly impacts a student's confidence and performance. Hence, results obtained from this research signifies that local anesthesia simulation kit is more effective in students performing local anesthesia. Thank you.
Thank you, presenters. Now we welcome the judges for the Q&A session.
Okay, Assalamualaikum. Nur Shahira. Okay, the twins. Okay, it was a very good study. Just that I'm quite confused with your objective of the study. May I know the main objective of your study? Can you tell me one main objective?
The first objective is that we want to construct and validate
You want to construct and
validate a questionnaire regarding the students' competency level in performing the INB.
All right.
And that's actually two objectives because we also want, as our title, refer to the patient satisfaction. So that's become also one of our objectives. We want to make sure their satisfaction in our study.
Yeah, because when I look at your objective, all right, and when I read your conclusion, it seems that in your conclusion, you are actually trying to look the effectiveness of using LAS, right? That's why you had this control and intervention punya group. Tapi kalau you tengok pula you punya study tu, you punya study objective or aims is only to evaluate students' perceived competency in performing apa tu inferior dental block. Kan? So you nak assess the competency level, or did you want to assess the effectiveness of LAS, or did you want to test the validity and reliability of your questionnaire B, USD LAS? So dia macam ada banyak sangat your aims and objective. But that macam yeah, bila I baca your abstract lah. Okay. First you want to do this, and then bila you baca you punya methods, is like suddenly there's a control group and intervention group. Oh, then suddenly there is a USD LAS, and then suddenly the conclusion it doesn't really tally lah. Itu je lah a bit, because whenever we do any research, we must be very firm with our study objective, study aims lah, and then baru you derive your study objective betul-betul. Alright, because I think it's quite confusing a bit lah. Okay, that's okay. Nanti you tengok balik. Okay, tapi you faham tak what I'm trying to say? Because kalau you tengok you punya presentation also, objective dia cakap lain kan. Lepas tu you punya the study findings so is a little bit different than your objective. Alright.
Prof,
Yep.
If I can answer to that question. We are trying it's true that we are trying to assess the students' competency level regarding performing the IMB. And then we're trying to come up with a result like whether with the aid of the LAS, it can help level up their competency level.
Then you are testing that thing.
It's like to
kan, tapi it was not really spelled out.
Shira, maybe you can.
Itu je lah, nanti tengok balik your write up. Alright, because you said you nak try tengok the competency, but then you inserting some other elements. It's like you're testing this the other two elements. It's okay. Another question before I pass over to Prof. Aida is do you think it's wise to validate questionnaire B, that is the USDL last tu kan? That is meant for patients, right? But you did a face validation on dental students. You think it's wise to do that? Is it appropriate? And another one also, you also for the questionnaire A, you validate it on first year dental students who have never been exposed to even needles.
Yeah.
You think it's wise to use these two study population for your face validation process?
Okay, thank you for the question. All right, first, because due to the current situation now, we weren't able to see real patients, hence only the students were picked to be the patients.
But is it appropriate?
The reason why we do face validation is because we want to test the reliability, design, grammar, and also the time spent to answer the questionnaire. Hence, for the construct validation that will be done later, we hope that the current questionnaire B will already be amended and also will already be modified.
Because the level, maybe if you look at the socioeconomic status or education status between dental students and also general patients, they may be different a bit. So I asked whether it's appropriate or not. Okay, that's all from me. Prof. Aida?
Much, Prof. Norintan. Well done, Shahira and Shahira. Okay, for your presentation. Okay, so I've got a question on whether are you looking at the correlation between, are you planning to find a correlation between your intervention group and also your control group? And are they using the same set of questions? It's a different, I see that you have got questionnaire A and B, but are the question actually related to each other?
Okay, thank you, Prof, for the question. First and foremost, questionnaire A and questionnaire B are for two different target groups. Questionnaire A is for the students, whereas questionnaire B is for the patients. And regarding for the correlation between control group and interventional group, we already assessed that there were differences between the perceivedness of their competency level.
So you want to assess the perception. Okay, yes. So another question is also about the face validation population, whether it's, I mean, maybe for year one, they're not really familiar with the terms. So I do agree with Prof. Norintan. And another last question is, why do you plan to do your construct validation in May? Is it because of short of time, or is it because there's any reason behind it?
Thank you for the question. First of all, regarding the first year dental undergraduate for our question A phase validation, is because it's like the first phase of our construction of questionnaire. So it's actually we want to test for the reliability, the grammar, the design of the questionnaire, and also the time they spend on answering the questionnaire. And the next question is sorry, Prof. But,
I can answer the question.
Thank you.
Okay, the reason why we conducting the real study for the second questionnaire in May is because inshallah by that time we will already be in the faculty and we can see patients, hence the real study will be conducted on real patients, not students.
Because the patients are still ongoing now, but probably not your own patient. So it has to be patient of the student, is it?
Yes.
To test whether your skill is good after the last.
Yes.
Okay, all right, got it. Thank you very much.
Thank you, Prof.
Thank you, judges.
Thank you, judges.
Thank you, judges and presenters. Before we move on to the next presentation, we would like to present the e-certificates for the presenters for your participation in this symposium. Let's move on to the last e-poster presentation for this morning session. Please welcome Nur Shakira binti Abdul Aziz and Nur Halida Sabrina binti Ikmal Hisam, who will be presenting on UiTM dental students' perspective on novel educational kits.
Assalamualaikum and good morning to all panel of judges, doctors and fellow audience. I am Nur Khalida Sabrina along with me Nur Shakira. Today we will be presenting our elective research project entitled UiTM Dental Student Perspective on Delivering Post-Dental Extraction Care Instruction with the aid of a novel educational kit. Our supervisor are Dr. Tan Soo Keng and Dr. Michelle Pelma. Dental extraction is one of the most common dental procedure, but its complication rate has been reported as high as 26%. That is why researchers have continuously emphasized the need and importance of patient education and their compliance after tooth extraction to reduce morbidity and to improve patient quality of life. Proper explanation to the patient regarding post-operative expectation, care instruction and potential complication can reduce their stress while improving satisfaction with the treatment received. Conventionally, post-operative care instruction was delivered verbally, but unfortunately it has been reported that patients can only remember 14% of the verbally given instruction, and therefore, verbal instruction alone is ineffective. Thus, a combination of different post-dental extraction care information delivery platforms, such as media and written form, to enhance its efficiency. Center of Studies for Oral Maxillofacial Surgery UiTM has introduced a novel patient educational kit known as Post-Dental Extraction Care Kit, which is PDEC kit. The kit includes a 2 minutes informative educational video, a smartphone application that will be available in both from iOS and Android format, a multilingual brochure with detailed instruction that can be brought home by patient, a set of do's and don'ts flashcards, an active model to practice manual socket compression in the dental clinic for effective bleeding control. This information is also easily accessible anywhere and everywhere by the provided QR code, which also includes the details of emergency contact number. Additionally, the PDEC kit has further expanded its applicability to patients with special needs such as blind and deafblind by providing a braille brochure detailing after dental extraction instruction. Therefore, PDEC kit can be used to enhance the post-op instruction delivery to the patient by dental student and general dental practitioner. Post-dental extraction instruction given by dental student and practitioner are often not systemic nor standardized, with some important aftercare information missing during the verbal delivery. As a result, patients were unable to practice proper wound care, resulting some potentially avoidable post-operative complications such as prolonged bleeding and delayed socket healing. Hence, a simple yet concise and precise patient education kit might be able to aid the dental student and dentist to provide effective post-dental extraction care to the patient. Therefore, the objective for this study is to assess UiTM dental student perspective on delivering post-extraction care instruction with the aid of a novel educational kit. Figure 1 shows the PDEC kit. For methodology, first, ethic approval from Research Ethics Committee UiTM was granted prior to the commencement of the study. The survey questions used in this study consist of 20 questions pertaining to the student perception and suggestion to improve PDEC kit. They were assessed with 7-point Likert scale and 7 open-ended questions, and the closed-ended questions were in a mixture of both positive and negative statements, including ease to use, usefulness, appropriateness of the content, beneficial in improving clinical practice, patient understanding, duration of the educational video, and etc. The face validity of the survey question was checked by 12 faculty members, and a pilot study was conducted on 50 fresh dental graduates to assess the content validity and reliability of the questionnaire. All clinical years dental students in UiTM were recruited into the study with a convenient sampling method. An 8-minute introductory video of PDEC kit was played to our participants, and next, the participant answered the online self-administered questionnaire that was validated together with demographic profile and market survey question. And lastly, All statistical analysis was performed with SPSS version 27. An independent t-test was used to compare the perception between student with and without dental extraction experience, while one-way ANOVA was used to compare the perception on PDAC kit among different clinical years dental students.
Next, let's move on the result. Table 1 shows the demographic profile of this study. 216 out of 246 clinical year students have participated in this study, which consists of 183 female and 33 male students. 211 students are Malay, while the others from other ethnicities. 69 of them were Year 3, 67 were Year 4, and 80 were Year 5 students. The ratio of participants with and without experience in dental extraction was nearly 1:1. Figure 2 shows UiTM dental students' perception on PDAC kit. Overall, the dental students have a very positive perception on PDAC kit. 13 out of 14 positive statements were agreed by more than 90% of the survey. Meanwhile, only 4 to 50% of the students have agreed with the 5 negative statements. Figure 3 shows the comparison of perception between students with and without dental extraction experience. It was interesting to find that the dental student with dental extraction experience have given higher score to the positive statement and lower score to the negative statement. The statistically significant difference was found in 10 positive and 1 negative statement. Figure 4 shows the comparison between different clinical year dental student perception on PDAC kit. Statistically, significant difference was found in 15 out of 20 statements. The post-hoc test has revealed that the significant difference was found mainly between Year 3 and Year 5 student 14 statement, followed by between Year 4 and Year 5 student 4 statement, and between Year 3 and Year 4 student 1 statement. Almost 1/3 of the participants think that the PDAC kit can help both patients and dentists to better understand the post-op instructions. A quarter of them believe it assists dentists to deliver better instruction. Other benefits mentioned including help the dentist not to miss any important point, aids the patient to remember in the instruction better, provides better visualization, better rapport between dentist and patient, able to provide better patient education, and simple and easy to use. Upon questioning the disadvantages of the kit, 38.7% of the dental students have stated that no disadvantages noted for the kit. The main disadvantages pointed out by 27.3% of the students is that the usage of the kit is too time consuming. The survey also has asked the participants' suggestion for additional tools to be included in the kit. More than half of the dental students think that the included tools are enough. Others have suggested oral hygiene kit, do's and don'ts of checklist, and a specialized kit for patients with special needs. The other suggestions included the tools that were pre-existing in the kit, but might have been missed out by the participant due to limitation of nature of an online survey. The study also has incorporated some market survey questions. Overall, the participants have provided a very positive response, which majority of them will buy the PDAC kit to aid their clinical practice as a dental student, 86.6%, and dentist 94.4%. Next, we will move on to the discussion. This study has a very good response rate of 87.8% from UiTM clinical year dental students. A vast majority of dental students agreed that the PDAC kit is useful, easy to use, and can improve patient understanding regarding post-dental extraction care instruction. As a result of impact of COVID-19 pandemic, half of the clinical year dental students have no actual clinical experience of dental extraction on patients. It was interesting to find that the students with dental extraction experience have given higher score to the positive statement, a lower score to the negative statement, signifying that those with experience acknowledge the difficulties in delivering an appropriate and effective post-extraction instruction, thus appreciate the aids of PDAC kit in their clinical practice better than those without experience. On the other hand, as every patient perceives information differently, the PDAC kit equipped with visual, audio, and tactile guide could cater the needs of everyone. However, the possibility of reducing the duration for those usage should be looked into as suggested by the participant. The main limitation of the study was the participant unable to experience the PDAC kit in person as this is an online survey. The students were having online classes at home due to the pandemic. Besides, a multi-center study involving dental students from other universities and also broader study groups involving in general dental practitioners in future research will be invaluable. Ladies and gentlemen, in conclusion, generally the UiTM data students have agreed that the PDAC kit is beneficial and can help them in delivering more effective post-dental extraction care instruction to the patient. And this is our references. With that, thank you.
Thank you, presenters. Now we would like to invite the judges for the Q&A session.
Poniati dulu ya.
Okay. Okay, Assalamualaikum, Nur Karidah and Nur Shakira. Nur Karidah. Okay, can you hear me?
Yes, Doctor.
Okay. Nur Shakira. Okay. Thank you. Good job for the presentation. I see that you got a very positive feedback from the respondent. All the scoring above 90%. My question, the first one, for your kid, is it only in English, or you also have the Malay language?
Thank you for the question. For the kid, we also include multilingual English. For now, it's only English and Bahasa Malaysia.
Okay, so you have future plan to include other language?
Yes, we have in the future we want to include like Mandarin or Tamil in our PDAC kit.
Okay, thank you. Okay, so the kid, okay, the 8 minutes introductory video. So you think, okay, when is the best time for you to actually show this kit or this video to the patient? Is it before the extraction or after the extraction? Because sometimes some of the patient, they are not willing to wait, after the extraction, they just want to go back. So you think when is the best time?
We for the video, we can show to the patient which is after the procedure, which is when they waiting for their bill or medication. So we can show the video so that they will watch the video while waiting their bills or medication.
Okay. So for now, using the traditional way, you also have the same list of question you deliver to the patient, or is it any additional question that you add in the list? Or you add in the kit, I mean, sorry. So for now, how you explain to the patient after the extraction?
For now, we just only use verbally, which is the student just explain the do's and don'ts of post extraction to the patient, which is no additional tools such as pictures or whatever. But with the aid of PDAC kit, they can show pictures, or by using tools model, we can show the proper compression technique so to avoid prolonged bleeding after post extraction.
Yeah, I like that. Okay, thank you. That's all from me.
Okay, Assalamualaikum. I see that your kit include a smartphone, yeah? So it is a very, very expensive kit, I assume. And but I think most students stated that they would buy the kit. Is it right?
Yes.
Okay, so it must include a smartphone lah. Betul eh?
The
Because when I
smartphone
read,
actually, the smartphone is not the phone, is the application of the smartphone.
Okay. So you tengok balik you punya poster lah, because you put smartphone, then I think it's very expensive then. Alright, okay. What is the implication of using this PDAC kit in clinic to patient dentist communication? Can you think of any implication? Implikasinya, implikasi kalau
for the patient, we expected that the patient have for the previously for the verbal, that patient don't really understand the instruction and they cannot imagine
Is there any evidence on that?
We have like there is like a study which said that there is for patients usually forget 40% to 80% of the verbal instruction when we give verbal instructions. So when we use PDAC kit, it can enhance the patient understanding and patient can remember better after the extraction, and we can reduce the complication after the extraction.
Right, but my question was, what is the implication of using this PDAC kit on patient-dentist communication? Ada implikasi tak?
Maybe there is, we less tend to communicate with patients, and then like we depends on the PDAC kit more to explain, so we have less interaction to ask the patient how to explain the instruction better.
Right, and then the dentist maybe pun lupa. Macam patient lupa tadi kan, bila kita bagi verbal instruction and if you
Dia
don't
macam
give the
neglect.
advice right, we will also forget. So that is one of the implication lah. Then maybe you would like to improve the kit so that it will not impact on dentist-patient communication, right? Another, and also dentist skills and knowledge also. Another thing, do you think it is appropriate to ask I mean you punya target group, how the kit can improve patients' understanding, because they are not the receiver end. Kan, they are the students, your target group ni kan, your sample size ni, your sample population ni, they are the providers end. Is it wise to ask them, do you think by using this kit, it will improve patients' understanding, it is appropriate for the patient? Do you think the questions are appropriate? Would you be able to answer on behalf of your patients?
Maybe like in further study, we want to test on the efficacy of the PDAC kit on patient. So during the study, we can ask how much the patient can understand.
Right, but in this study, your sample size is dental students. Nanti study nanti tu nantilah kan. Alright, but in the first place, who constructed the questionnaire, and has it been phase or content validated? The questionnaire that you use, who constructed it?
The questionnaire is constructed by both us and our supervisor, and after that the questionnaire will do phase validity with by 12 faculty members, and also the questionnaire is tested on pilot study on 50 fresh graduate to assess the validity and reliability of the questionnaire.
Right. So it seems that you have gone through the validation process. So it seems that the questions that you ask on whether it can improve on patients' understanding or whether it's appropriate for patients to valid lah ya. Kan? That means dental students can answer on behalf of the patients. They can gauge patients' perception. That is good. Okay, I think that is novel. All right. I think that's all. Good luck. Hopefully you'll be a millionaire soon with this kit. Okay.
All right. Thank you, Prof.
Thank you, Prof.
Thank you, judges.
Thank you, judges and presenters. Before we move on to the next before we end this session, we would like to present the e-certificates for the presenters for your participation in this symposium. So this concludes our e-poster presentation for this morning session. Thank you all for attending. We hope you have learned and enjoyed along the way. We hope to see you in the afternoon session of this poster presentation, which will start at 2 p.m. In the meantime, we will play the Tadarus by our students.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قال ألم أقل لك إنك لن تستطيع معي صبرا قال إن سألتك عن شيء بعدها فلا تصاحبني قد بلغت من لدني عذرا فانطلقا حتى إذا أتيا أهل قرية استطعما أهلها فأبوا أن يضيفوهما فوجدا فيها جدارا يريد أن ينقض فأقامه قال لو شئت لاتخذت عليه أجرا قال هذا فراق بيني وبينك سأنبئك بتأويل ما لم تستطع عليه صبرا أما السفينة فكانت لمساكين يعملون في البحر فأردت أن أعيبها وكان وراءهم ملك يأخذ كل سفينة غصبا وأما الغلام فكان أبواه مؤمنين فخشينا أن يرهقهما طغيانا وكفرا فأردنا أن يبدلهما ربهما خيرا منه زكاة وأقرب رحما وأما الجدار فكان لغلامين يتيمين في المدينة وكان تحته كنز لهما وكان أبوهما صالحا فأراد ربك أن يبلغا أشدهما ويستخرجا كنزهما رحمة من ربك وما فعلته عن أمري ذلك تأويل ما لم تستطع عليه صبرا ويسألونك عن ذي القرنين قل سأتلو عليكم منه ذكرا إن مكنا له في الأرض وآتيناه من كل شيء سببا فأتبع سببا حتى إذا بلغ مغرب الشمس وجدها تغرب في عين هامئة ووجد عندها قوما قلنا يا ذا القرنين إما أن تعذب وإما أن تتخذ فيهم حسنا قال أما من ظلم فسوف نعذبه ثم يرد إلى ربه فيعذبه عذابا نكرا وأما من آمن وعمل صالحا فله جزاء الحسنى وسنقول له من أمرنا يسرا ثم أتبع سببا حتى إذا بلغ مطلع الشمس وجدها تطلع على قوم لم نجعل لهم من دونها سترا كذلك وقد أخذنا بما لديه خبرا ثم أتبع سببا حتى إذا بلغ بين السدين وجد من دونهما قوما لا يكادون يفقهون قولا قالوا يا ذا القرنين إن يأجوج ومأجوج مفسدون في الأرض فهل نجعل لك خرجا على أن تجعل بيننا وبينهم سدا قال ما مكني فيه ربي خير فأعينوني بقوة أجعل بينكم وبينهم ردما آتوني زبر الحديد الحديد حتى إذا ساوى بين الصدفين قال انفخوا حتى إذا جعله نارا قال آتوني أفرغ عليه قطرا فما استطاعوا أن يظهروه وما استطاعوا له نقبا قال هذا رحمة من ربي فإذا جاء وعد ربي جعله دكا وكان وعد ربي حقا وتركنا بعضهم يومئذ يموج في بعض ونفخ في السور فجمعناهم جمعا وعرضنا جهنم يومئذ للكافرين عرضا الذين كانت أعينهم في غطاء عن ذكري وكانوا لا يستطيعون سمعا أفحسب الذين كفروا أن يتخذوا عبادي من دوني أولياء إنا أعتدنا جهنم للكافرين نزلا قل هل ننبئكم بالأخسرين أعمالا الذين ضل سعيهم في الحياة الدنيا وهم يحسبون أنهم يحسنون صنعا أولئك الذين كفروا بآيات ربهم ولقائه فهبطت أعمالهم فلا نقيم لهم يوم القيامة وزنا ذلك جزاؤهم جهنم بما كفروا واتخذوا آياتي ورسلي هزوا إن الذين آمنوا وعملوا الصالحات كانت لهم جنات الفردوس نزلا خالدين فيها لا يبغون عنها حولا قل لو كان البحر مدادا لكلمات ربي لنفد البحر قبل أن تنفد كلمات ربي ولو جئنا بمثله مددا قل إنما أنا بشر مثلكم يوحى إلي أنما إلهكم إله واحد فمن كان يرجو لقاء ربي فليعمل عملا صالحا ولا يشرك بعبادة ربه أحدا صدق الله العظيم أعوذ بالله من الشيطان الرجيم لكنه الله ربي ولا أشرك بربي أحدا ولولا إذ دخلت صفا لقد جئتمونا كما خلقناكم أول مرة بل زعمتم أن لن نجعل لكم موعدا ووضع الكتاب فترى المجرمين مشفقين مما فيه ويقولون يا ويلتنا ما لهذا الكتاب لا يغادر صغيرة ولا كبيرة إلا أحصاها ووجدوا ما عملوا حاضرا ولا يظلم ربك أحدا وإذ قلنا للملائكة اسجدوا لآدم فسجدوا إلا إبليس كان من الجن ففسق عن أمر ربه أفتتخذونه وذريته أولياء من دوني وهم لكم عدو بئس للظالمين بدلا ما أشهدتهم خلق السماوات والأرض ولا خلق أنفسهم وما كنت متخذ المضلين عضدا ويوم يقول نادوا شركائي الذين زعمتم فدعوهم فلم يستجيبوا لهم وجعلنا بينهم موبقا ورأى المجرمون النار فظنوا أنهم مواقعها ولم يجدوا عنها مصرفا ولقد صرفنا في هذا القرآن للناس من كل مثل وكان الإنسان أكثر شيء جدلا وما منع الناس أن يؤمنوا إذ جاءهم الهدى ويستغفروا ربهم إلا أن تأتيهم سنة الأولين أو يأتيهم العذاب قبلا وما نرسل المرسلين إلا مبشرين ومنذرين ويجادل الذين كفروا بالباطل ليدحضوا به الحق واتخذوا آياتي وما أنذروا هزوا ومن أظلم ممن ذكر بآيات ربه فأعرض عنها ونسي ما قدمت يداه إنا جعلنا على قلوبهم أكنة أن يفقهوه وفي آذانهم وقرا وإن تدعوهم إلى الهدى فلن يهتدوا إذا أبدا وربك الغفور ذو الرحمة لو يؤاخذهم بما كسبوا لعجل لهم العذاب بل لهم موعد لن يجدوا من دونه موئلا وتلك القرى أهلكناهم لما ظلموا وجعلنا لمهلكهم موعدا وإذ قال موسى لفتاه لا أبرح حتى أبلغ مجمع البحرين أو أمضي حقبا فلما بلغا مجمع بينهما نسيا حوتهما فاتخذ سبيله في البحر سربا فلما جاوزا قال لفتاه آتنا وداءنا لقد لقينا من سفرنا هذا نصبا قال أرأيت إذ أوينا إلى الصخرة فإني نسيت الحوت وما أنساني إلا الشيطان أن أذكره واتخذ سبيله في البحر عجبا قال ذلك ما كنا نبغي فارتد على آثارهما قصصا فوجدا عبدا من عبادنا آتيناه رحمة من عندنا وعلمناه من لدنا علما قال له موسى هل أتبعك على أن تعلمني مما علمت رشدا قال إنك لن تستطيع معي صبرا وكيف تصبر على ما لم تحط به خبرا قال ستجدني إن شاء الله صابرا ولا أعصي لك أمرا قال فإن اتبعتني فلا تسألني عن شيء حتى أحدث لك منه ذكرا فانطلقا حتى إذا ركبا في السفينة خرقها قال أخرقتها لتغرق أهلها لقد جئت شيئا إمرا قال ألم أقل إنك لن تستطيع معي صبرا قال لا تؤاخذني بما نسيت ولا ترهقني من أمري عسرا فانطلقا حتى إذا لقيا غلاما فقتله قال أقتلت نفسا زكية بغير نفس
أنزل على عبده الكتاب ولم يجعل له عوجا قيما لينذر بأسا شديدا من لدنه ويبشر المؤمنين الذين يعملون الصالحات أن لهم أجرا حسنا ماكثين فيه أبدا وينذر الذين قالوا اتخذ الله ولدا ما لهم به من علم ولا لآبائهم كبرت كلمة تخرج من أفواههم إن يقولون إلا كذبا فلعلك باخع نفسك على آثارهم إن لم يؤمنوا بهذا الحديث أسفا إنا جعلنا ما على الأرض زينة لها لنبلوهم أيهم أحسن عملا وإنا لجاعلون ما عليها صعيدا جرزا أم حسبت أن أصحاب الكهف والرقيم كانوا من آياتنا عجبا إذ أوى الفتية إلى الكهف فقالوا ربنا آتنا من لدنك رحمة وهيئ لنا من أمرنا رشدا فضربنا على آذانهم في الكهف سنين عددا ثم بعثناهم لنعلم أي الحزبين أحصى لما لبثوا أمدا نحن نقص عليك نبأهم بالحق إنهم فتية آمنوا بربهم وزدناهم هدى وربطنا على قلوبهم إذ قاموا فقالوا ربنا رب السماوات والأرض لن ندعو من دونه إلها لقد قلنا إذا شططا هؤلاء قومنا اتخذوا من دونه آلهة لولا يأتون عليهم بسلطان بين فمن أظلم ممن افترى على الله كذبا وإذ اعتزلتموهم وما يعبدون إلا الله فأووا إلى الكهف ينشر لكم ربكم من رحمته ويهيئ لكم من أمركم مرفقا وترى الشمس إذا طلعت تزاور عن كهفهم ذات اليمين وإذا غربت تقرضهم ذات الشمال وهم في فجوة منه ذلك من آيات الله من يهد الله فهو المهتد ومن يضلل فلا تجد له وليا مرشدا وتحسبهم أيقاظا وهم رقود ونقلبهم ذات اليمين وذات الشمال وكلبهم باسط ذراعيه بالوصيد لو اطلعت عليهم لوليت منهم فرارا ولملئت منهم رعبا وكذلك بعثناهم ليتساءلوا بينهم قال قائل منهم كم لبثتم قالوا لبثنا يوما أو بعض يوم قالوا ربكم أعلم بما لبثتم فابعثوا أحدكم بورقكم هذه إلى المدينة فلينظر أيها أزكى طعاما فليأتكم برزق منه وليتلطف ولا يشعرن بكم أحدا إنهم إن يظهروا عليكم يرجموكم أو يعيدوكم في ملتهم ولن تفلحوا إذا أبدا وكذلك أعثرنا عليهم ليعلموا أن وعد الله حق وأن الساعة لا ريب فيها إذ يتنازعون بينهم أمرهم فقالوا ابنوا عليهم بنيانا ربهم أعلم بهم قال الذين غلبوا على أمرهم لنتخذن عليهم مسجدا سيقولون ثلاثة رابعهم كلبهم ويقولون خمسة سادسهم كلبهم رجما بالغيب ويقولون سبعة وثامنهم كلبهم قل ربي أعلم بعدتهم ما يعلمهم إلا قليل فلا تمار فيهم إلا مراء ظاهرا ولا تستفت فيهم منهم أحدا ولا تقولن لشيء إني فاعل ذلك غدا إلا أن يشاء الله واذكر ربك إذا نسيت وقل عسى أن يهديني ربي لأقرب من هذا رشدا ولبثوا في كهفهم 300 سنين وازدادوا 9 قل الله أعلم بما لبثوا له غيب السماوات والأرض أبصر به وأسمع ما لهم من دونه من ولي ولا يشرك في حكمه أحدا فاتل ما أوحي إليك من كتاب ربك لا مبدل لكلماته ولا تجد من دونه ملتحدا واصبر نفسك مع الذين يدعون ربهم بالغداة والعشي يريدون وجهه ولا تعد عيناك عنهم تريد زينة الحياة الدنيا ولا تطع من أغفلنا قلبه عن ذكرنا واتبع هواه وكان أمره فرطا وقل الحق من ربكم فمن شاء فليؤمن ومن شاء فليكفر إنا أعتدنا للظالمين نارا أحاط بهم سرادقها وإن يستغيثوا يغاثوا بماء كالمهل يشوي الوجوه بئس الشراب وساءت مرتفقا إن الذين آمنوا وعملوا الصالحات إنا لا نضيع أجر من أحسن عملا أولئك لهم جنات عدن تجري من تحتهم الأنهار يحلون فيها من أساور من ذهب ويلبسون ثيابا خضرا من سندس واستبرق متكئين فيها على الأرائك نعم الثواب وحسنت مرتفقا واضرب لهم مثل الرجلين جعلنا لأحدهما جنتين من أعناب وحففناهما بنخل وجعلنا بينهما زرعا كلتا الجنتين آتت أكلها ولم تظلم منه شيئا وفجرنا خلالهما نهرا وكان له ثمر فقال لصاحبه وهو يحاوره أنا أكثر منك مالا وأعز نفرا ودخل جنته وهو ظالم لنفسه قال ما أظن أن تبيد هذه أبدا وما أظن الساعة قائمة ولئن رددت إلى ربي لأجدن خيرا منها منقلبا قال له صاحبه وهو يحاوره أكفرت بالذي خلقك من تراب ثم من نطفة ثم سواك رجلا
يبسط الرزق لمن يشاء ويقدر وفرحوا بالحياة الدنيا وما الحياة الدنيا في الآخرة إلا متاع ويقول الذين كفروا لولا أنزل عليه آية من ربه قل إن الله يضل من يشاء ويهدي إليه من أناب الذين آمنوا وتطمئن قلوبهم بذكر الله ألا بذكر الله تطمئن القلوب الذين آمنوا وعملوا الصالحات طوبى لهم وحسن مآب كذلك أرسلناك في أمة قد خلت من قبلها أمم لتتلو عليهم الذي أوحينا إليك وهم يكفرون بالرحمن قل هو ربي لا إله إلا هو عليه توكلت وإليه متاب ولو أن قرآنا سيرت به الجبال أو قطعت به الأرض أو كلم به الموتى بل لله الأمر جميعا أفلم ييأس الذين آمنوا أن لو يشاء الله لهدى الناس جميعا ولا يزال الذين كفروا تصيبهم بما صنعوا قارئة أو تحل قريبا من دارهم حتى يأتي وعد الله إن الله لا يخلف الميعاد ولقد استهزئ برسل من قبلك فأمليت للذين كفروا ثم أخذتهم فكيف كان عقاب أفمن هو قائم على كل نفس بما كسبت وجعلوا لله شركاء قل سمهم أم تنبئونه بما لا يعلم في الأرض أم بظاهر من القول بل زين للذين كفروا مكرهم وصدوا عن السبيل ومن يضلل الله فما له من هاد لهم عذاب في الحياة الدنيا والعذاب الآخرة أشق وما لهم من الله من واق مثل الجنة التي وعد المتقون تجري من تحتها الأنهار أكلها دائم وظلها تلك عقبى الذين اتقوا وعقبى الكافرين النار والذين آتيناهم الكتاب يفرحون بما أنزل إليك ومن الأحزاب من ينكر بعضه قل إنما أمرت أن أعبد الله ولا أشرك به إليه أدعو وإليه مآب وكذلك أنزلناه حكما عربيا ولئن اتبعت أهواءهم بعدما جاءك من العلم ما لك من الله من ولي ولا واق ولقد أرسلنا رسلا من قبلك وجعلنا لهم أزواجا وذرية وما كان لرسول أن يأتي بآية إلا بإذن الله لكل أجل كتاب يمحو الله ما يشاء ويثبت وعنده أم الكتاب وإما نرينك بعض الذي نعدهم أو نتوفينك فإنما عليك البلاغ علينا الحساب أولم يروا أن نأتي الأرض ننكسها من أطرافها والله يحكم لا معقب لحكمه وهو سريع الحساب وقد مكر الذين من قبلهم فلله المكر جميعا يعلم ما تكسب كل نفس وسيعلم الكفار لمن عقبى الدار ويقول الذين كفروا لست مرسلا قل كفى بالله شهيدا بيني وبينكم ومن عنده علم الكتاب بسم الله الرحمن الرحيم ألف لام تلك آيات الكتاب الذي أنزل إليك من ربك الحق ولكن أكثر الناس لا يؤمنون الله الذي رفع السماوات بغير عمد ترونها ثم استوى على العرش وسخر الشمس والقمر كل يجري لأجل مسمى يدبر الأمر يفصل الآيات لعلكم بلقاء ربكم توقنون وهو الذي مد الأرض وجعل فيها رواسي وأنهارا ومن كل الثمرات جعل فيها زوجين اثنين يغشي الليل النهار إن في ذلك لآيات لقوم يتفكرون وفي الأرض قطع متجاورة وجنة من أعناب وزرع ونخيل صنوان وغير صنوان يسقى بماء واحد ويفضل بعضها على بعض في الأكل إن في ذلك لآيات لقوم يعقلون وإن تعجب فعجب قولهم أئذا كنا ترابا ويستعجلونك بالسيئات قبل الحسنة وقد خلت من قبلهم المثلات وإن ربك لذو مغفرة للناس على ظلمهم وإن ربك لشديد العقاب ويقول الذين كفروا لولا أنزل عليه آية من ربه إنما أنت منذر ولكل قوم هاد الله يعلم ما تحمل كل أنثى وما تغيض الأرحام وما تزداد وكل شيء عنده بمقدار عالم الغيب والشهادة الكبير المتعال سواء منكم من أسر القول ومن جار به ومن هو مستخف بالليل وسارب بالنهار له مؤقبة من بين يديه ومن خلفه يحفظونه من أمر الله إن الله لا يغير ما بقوم حتى يغيروا ما بأنفسهم وإذا أراد الله بقوم سوءا فلا مرد له وما لهم من دونه من وال وهو الذي يريكم البرق خوفا وطمعا وينشئ السحاب الثقال ويسبح الرعد بحمده والملائكة من خيفته ويرسل الصواعق فيصيب بها من يشاء وهم يجادلون في الله وهو شديد المحال له دعوة الحق والذين يدعون من دونه لا يستجيبون لهم بشيء إلا كباسط كفيه إلى الماء ليبلغ فاه وما هو ببالغه وما دعاء الكافرين إلا في ضلال ولله يسجد من في السماوات والأرض طوعا وكرحا وظلالهم بالغدو والأصال قل من رب السماوات والأرض قل الله قل أفاتخذتم من دونه أولياء لا يملكون لأنفسهم نفعا ولا ضرا قل هل يستوي الأعمى والبصير أم هل تستوي الظلمات والنور أم جعلوا لله شركاء خلقوا كخلقه فتشابه الخلق عليهم قل الله خالق كل شيء وهو الواحد القهار أنزل من السماء ماء فسلت أودية بقدرها فاحتمل السيل زبدا رابيا ومما يوقدون عليه في النار ابتغاء حلية أو متاع زبد مثله كذلك يضرب الله الحق والباطل فأما الزبد فيذهب جفاء وأما من ينفع الناس فيمكث في الأرض كذلك يضرب الله الأمثال للذين يستجاب لربهم الحسنى والذين لم يستجيبوا له لو أن لهم ما في الأرض جميعا ومثله معه لافتدوا به أولئك لهم سوء الحساب ومأواهم جهنم وبئس المهاد أفمن يعلم أنما أنزل إليك من ربك الحق أفمن يعلم أنما أنزل إليك من ربك الحق كمن هو أعمى إنما يتذكر أولو الألباب الذين يوفون بعهد الله ولا ينقضون الميثاق والذين يصلون ما أمر الله به أن يوصل ويخشون ربهم ويخافون سوء الحساب والذين صبروا ابتغاء وجه ربهم وأقاموا الصلاة وأنفقوا مما رزقناهم سرا وعلانية ويدرؤون بالحسنة السيئات أولئك لهم عقبى الدار جنة عدن يدخلونها ومن صلح من آبائهم وأزواجهم وذرياتهم والملائكة يدخلون عليهم من كل باب سلام عليكم بما صبرتم فنعم عقبى الدار والذين ينقضون عهد الله من بعده ميثاقه ويقطعون ما أمر الله به أن يوصل ويفسدون في الأرض أولئك لهم اللعنة ولهم سوء الدار
There's no one I can turn to. And I know all the feelings that we shared are in the past. And I know your relationships are never meant to last. And I'll take some time, but I'll be alright. Moving on, moving on.
show you some easy exercises as well as some stretches that you can do whether you're at home, at work, whenever you need a little break so that you can maintain a proper posture for the health and strength of your back. Let's get started. The first thing that you want to keep in mind is your posture when you're sitting down, especially at your desk. You don't want to slouch, but instead you want to be upright. You gotta keep your chest up, your head up, your back straight, and your shoulders up. Also, remember to take a little break every hour or so whenever you're working or whenever you're gaming. Now, for some exercises that you can do, you gotta keep your back straight and you can roll your shoulders backwards for a set of 10, and you can also roll your shoulders forward for a set of 10. So 10 forward and also 10 backwards. Lastly, you can do the stretch at your desk. You can put your hand above your elbow and you can stretch your elbow. Lastly, you can do this stretch at your desk. You put your right hand above your elbow and you pull it down and you drop your head at the opposite side. You want to hold this position for about 10 to 15 seconds. This will be able to stretch out your trapezius muscles and help you to relax your back as well as your neck. These are little stretches that you can do right at your desk. Remember, posture is really important, so keep your back straight, your chin up, and your shoulders squared. Next, I'm going to show you some tips and eye exercises that will help eye strain due to computer vision syndrome. Let's take a look. A lot of us these days are spending more time in front of a computer screen or cell phone throughout the day, and when we spend this much time on a device that is only a few feet away from our face, it can cause muscle strain to our eyes. So, tip number 1 is to take frequent breaks. When you stare at a digital device for too long, your muscles will start to cramp up, and we call this as the accommodative spasm. To help relieve this, follow the 20-20-20 rule, which means that for every 20 minutes you spend in front of a device, take about 20 seconds rest and looking at 20 feet away in the distance, just so that you can give your eye muscles a bit of a rest. Adjusting your environment can also reduce the risk of developing computer vision syndrome. What you can do is adjust your screen position. And lastly, you can use your eyes to look at different directions and hold it for at least 5 seconds. You can start by looking outward and hold it for 5 seconds, and you can repeat it at a different direction, whether you can go downwards, repeat for 5 seconds, and looking sideways. Hope these tips and exercises are helpful for you to practice anytime and anywhere. Enjoy the rest of the event and stay safe!
Assalamualaikum and a very good afternoon to all honorable judges, professors, doctors, lecturers, and fellow friends. Welcome to the 11th UiTM Dental Student Scientific Symposium. Our theme this year is Dentistry Against All Odds, Revolutionizing Research and Practice. This e-poster presentation is streamed on our live telecast YouTube channel. Therefore, we would like to request all presenters and all symposium participants to fill in the attendance link on our website for this afternoon session. I am Adlina Zulkifli and I will be your moderator for this afternoon session, and along with Iza Arif as our timekeeper. Before we begin, please allow me to lay down a few house rules for today's session. All presenters must be ready at least 10 minutes prior to your allocated presentation time. All presenters are required to use the provided virtual background on our website for the live Q&A session. The pre-recorded video presentation will be played by the committee for 10 minutes and subsequently followed by a 5-minute Q&A session by the Q&A session by the judges. For the presenters, please ensure your camera and microphone is turned on only during this session. First bell will be rang at 4 minutes of the Q&A session. Second bell will be rang at the 5 minutes of the Q&A session, and the last multiple bell will be rang at the end of this session. After the Q&A session ends, the moderator will queue for the next presenter. In case of any technical difficulties during the video presentation or the Q&A session, other presenters must be ready on standby and should the allocated time be brought forward or earlier. Without further ado, let's start with our first recorded poster presentation for this afternoon by Nurdiana Yap, binti Aiman Faziriab and Adina binti Rosli with their research topic of stress and its association with eating behavior among dental students UiTM.
Assalamualaikum and good afternoon. I am Diana. Today, me and my partner Adina will be presenting our research with the title of Stress and its Association with Eating Behaviors among UiTM's dental students. We were supervised by Madam Vivian Noryati Ahmad and Madam Izian Hazwani Baharuddin. I will start with the background of our study. Stress is a normal body's reaction to any changes that requires an adjustment or response. The body reacts to the changes of physical, mental, and emotional responses. Generally, stress occurs when there are demands on individuals that exceed their coping capabilities, and the way they react varies depending on the nature of events and characteristics of the individual itself. According to Harmon et al., acute stress is the stress that occurs in a short period of time where the response can be appropriate or even beneficial. This kind of stress is generally harmless. However, when it is prolonged, it then becomes chronic, which can cause a range of symptoms that can contribute to the development of physical and mental disorders. High level of stress associated with dental practitioners was reported to have the prevalence of 89.7% in Malaysia, and it appears to begin during dental school. It is manifested differently during different years of study. Dental education has long been recognized as complex and highly demanding training. Stress becomes harmful and affects health when people engage in certain behaviors to try to relieve this stress. Change in diet habit is one such behavior. Although there is a widespread acceptance of relationship between stress and eating behaviors, the findings have been found to be inconsistent. According to study done by Divyadarshini et al., stress appears to alter overall food intake in two ways, that are undereating and overeating. When one tends to overeat due to chronic stress, it is causally linked to weight gain and contributing to obesity, as well as all the health problems associated with it. In some cases, other individuals decrease their food intake during stress, and this behavior could also cause adverse health effects. Rather than relieving the stress and returning the body to a relaxed state, the unhealthy eating behavior tends to keep the body in a stress state, and this person becomes trapped in a vicious cycle that ends up causing more health problems. The objectives of our study was to investigate the eating behavior as well as the association between stress and eating behavior among dental students in University Technology Mara UiTM. Moving on to our methods of study, our study design was a cross-sectional study that was conducted among undergraduate dental students in Faculty of Dentistry UiTM Sungai Buloh campus, which was our source of population. The participants that were included in this study were students in their first to fifth year of undergraduate study, active students, and students who understand English. There were no exclusion criteria for our study. Following the criteria, undergraduate students of UiTM Sungai Buloh were eligible to take part in this survey. Our sample size was 199 with AP info of alpha equals to 0.05. Our data collection was done through Google Form and it was divided into 4 sections. Participants were required to answer all questions. The first section of the Google Form contains subject information sheet and consent form. For our study, there were 2 measurement tools. First was the perceived stress scale. It was extracted from questionnaire that has been validated by Cohen and Williamson 1988. This instrument consists of 4 items that focus on the appraisal of stress and coping over the period of 1 month. The responses are made based on a 5-point Likert scale: never, rarely, sometimes, often, and very often. All of the items are then added together to produce a cumulative perceived stress score. Next is the Adult Eating Behavior Questionnaire, which was validated by Who Not et al. 2016. The questionnaire consists of 8 domains: enjoyment of food, emotional overeating, emotional undereating, food fussiness, food responsiveness, slowness in eating, hunger, and satiety responsiveness. Data analysis was conducted using Statistical Package for Social Science SPSS IBM version 25. The data was then analyzed using descriptive statistics, Pearson's correlation, and simple linear regressive analysis.
Continue with our result. There were 232 out of 409 undergraduate students who have answered the questionnaire, giving a response rate of 56.7%. The mean age of the respondent was 22 years old, and the respondents were predominantly female by 81.9% and followed by male by 18.1%. In addition, the mean height of the students was 158.1 cm and the mean weight was 54.7 kg, hence making the BMI of the students 22.3 kg per meter squared. The first table shows UiTM dental students' eating behaviors and stress level. The highest eating behavior score was 24.6 for enjoyment of food, followed by 16.4 for food fussiness, 15.5 for emotional undereating, 13.7 for emotional overeating, 13 for food responsiveness, then followed by slowness in eating with the mean of 11.8, and lastly satiety responsiveness with the mean of 10.9. The mean for the stress score was 24, which showed most respondents were stressed. Table 2 then shows the association between stress and eating behaviors among students. Firstly, there was no significant association between stress and enjoyment of food. Next, there was a fair correlation between stress and emotional overeating score, where when there is 1 unit increase in stress score, there is increase in emotional overeating by 0.189. Besides that, there was a significant correlation between stress and emotional undereating among UiTM dental students. With 1 unit increase in stress score, the emotional undereating score will increase by 0.164. In addition to that, there was a significant fair correlation between stress and food fussiness, with 1 unit increase in stress score versus an increase in the food fussiness score by 0.136. There was a significant fair correlation between stress and food responsiveness score, where when 1 unit of stress score was increased, there was an increase in food responsiveness by 0.202. Furthermore, there was no significant association between stress and slowness in eating score among UiTM dental students. There was a significant fair correlation between stress and hunger score. 1 unit increase in stress score increased the hunger score by 0.320. Lastly, there was no significant association between stress and satiety responsiveness score among the students. Next, I'll continue with the discussion and conclusion. To our knowledge, there were cross-sectional studies conducted on the prevalence of stress, stress perception, and the factors contributing to stress in the Faculty of Dentistry UiTM. However, the association between stress and eating behaviors, on the other hand, has yet to be studied and it is still unclear. Hence, this research is needed to investigate this matter. The prevalence of stress among dentists was stated to be 89.7% in Malaysia. High levels of stress are linked to dentists and it tends to start during dental school. In this current study, the average stress score among UiTM undergraduate dental students obtained was 24.02 out of 40, which is higher than reported by the general population. In this study, it shows that there was a fair correlation between stress with emotional overeating, emotional undereating, hunger, food fussiness, and food responsiveness. There was a study done by Ling and Zari showed that emotional eating was positively linked to perceived stress, which was consistent with our findings of our research that showed fair correlation between stress and emotional overeating and emotional undereating. Studies have shown that some people prefer to eat more in stressful environments, while others experience a reduction in appetite and eat less. There is a fair correlation between stress and hunger, which may be one of the causes to emotional overeating and then may lead to obesity. There is no association between stress and satiety responsiveness, enjoyment of food, and slowness in eating. There were several challenges that we faced during this research. One of the challenges that we faced were geographical constraints. The study was conducted at a single faculty, which includes UiTM Faculty of Dentistry only. Therefore, the results of other faculties could not be reflected clearly. In conclusion, the findings of this study indicated that stress is linked to 5 of the 8 eating behavior studied. The results suggested that students should be aware of how their stress affects their healthy or unhealthy eating behaviors, along with its adverse health effects. And these are our references. With that, thank you.
Thank you, presenters. Now we would like to invite the judges for the Q&A session.
Assalamualaikum. Good afternoon, Adina and Diana. Well done for your presentation and for having to this stage, finishing your ERP. Okay, I have one question on your exclusion criteria. So, you stated that there is no exclusion criteria in your questionnaire. Do you think that is right since you have got a few inclusion criteria there? Do you think there's a possibility that our students also about English, for example? Right, Diana, you would like to answer?
Yes, Doctor. We wanted to include everyone for this study. So among our study population, there were no criteria that could contribute to biasness, which require us to include in exclusion. As you were saying about English language, so our questionnaire was in English, even though subjects were Malaysian. The reason are firstly, the medium language for our academic and research purpose in this faculty is English. So it is a no issue for students to understand the question survey. And secondly, we wanted to use English because the original question from Huno et al. 2016 and Cohen and Williamson 1988 were also in English, and it has been validated. Hence, to minimize the wrong translation or understanding, so we decided to use English.
Okay, thank you. Another question is, what is the clinical significance of your study? Or is there any, can you tell me about the significance of the study, the findings that you had in your work?
The findings of the study indicated that stress is linked to 5 out of 8 eating behavior studied. However, the relationship between stress and eating habits is still poorly understood among dental students. For example, students realize they tend to eat more during when they are stressed out, or they tend to eat less when they are stressed out. However, they do not know the consequences of it. For example, it could be our study could be used as an early warning to avoid eating disorders and diseases associated with them.
Okay, thank you very much, Adina. I'll pass the Q&A session to the judge.
Thank you, Dr. Aida. Assalamualaikum, Diana and Adina. So congratulations. Okay, you did a good presentation today. My question, okay, I know that you use the validated questionnaire, okay, 2 set of questionnaire, perceived stress scale and adult eating behavior scale. My question, did you run a pilot test for this questionnaire in your population? I mean the dental student. Did you do a pilot test?
No,
to
we did not.
see whether the okay. And then okay, it's stated in the abstract here, the cross-section study conducted among 409 undergraduate dental students, but I saw in on your poster it's mentioned 199. That 199 is the respondent.
199 is minimum sample size, madam.
Okay, minimum sample size. So your total sample size is 409.
Yes, madam. However, our response rate.
And then 65%. Okay. Okay, so okay, what is I think when we talk something when you do a questionnaire about stress, okay, is it something qualitative? So you think what is the limitations of the study of your study here?
The students who are yes, madam.
Maybe why you think that your response rate is only 65%? So any idea?
Prior to the COVID-19 pandemic, we were required to distribute our questionnaire online instead of doing it face to face. So hence we only had the respondents rate of 65%.
So if we have it face to face, I think you will get more, right?
Yes, madam.
Yes, madam.
Okay. Okay. So it's already tea time. Okay, so during your study, your sample or your respondent were actually at home, right? Or some
Yeah.
at the hostel or some at home? All
Some
at home.
hostel and some at home.
So do you think their location, because some at the RC where they don't have access, access compared to the one at the home, the house, okay, access to food. Do you think there's any significant effects on the response?
Personally, I don't think so, madam, because whether it's at home or in college, both places have Wi-Fi, so they would be able to answer the questionnaire online. They should be able to answer.
But how about their access to food?
Oh.
And how about the stress level? Because
Yes, madam, it would be a bit different.
Madam, I think the access to
So-
food would be different, but the stress level would be the same because we still go through online classes.
Okay. Okay, thank you.
Do you think online classes
that's all from
and the physical classes will be different or the same?
Different, doctor.
And if it is different, then do you think administering your questionnaire for the students in the hostel and also at home will be different?
The students in the hostel and students at home both have to face online classes, doctor. So I think there would the stress scale would be about the same.
Okay.
Okay.
Do you have time for more question or pass? Okay, that's all.
All right, thank you, doctors and madam.
Thank you.
Thank you, presenters and judges. Now, before we move on to the next presentation, we would like to present the e-certificates for the presenters for your participation in this symposium. Now let's continue to the next presentation. Please welcome Hanan Safian binti Muhammad Anwar and Tengku Nurfati Nabila binti Tuan Muhammad Zaki with their research topic of an app-based diagnostic tool of oral medicine teaching, a prospective survey on the impact of learning.
Assalamualaikum and a very good evening to the honorable panel judges, lecturers and my fellow friends. I am Hana Safian Anwar and along with me, my research partner Tengku Fatina Bila will be presenting our research entitled An App Based on Diagnostic Tool, a Survey on the Impact of Learning. To start with the presentation, I would like to elaborate more about the background of the study. Oral medicine is a branch of dentistry that lies at the interface between medicine and dentistry and is particularly related to diagnosing and managing oral diseases. Achieving accurate diagnosing of oral disease is critical in formulating appropriate treatment plans for the patient. Learning OM can be challenging for some undergraduate dental students due to overwhelmed theoretical and clinical concepts. At the moment, OM education has been delivered in a customary classroom in all dental schools in Malaysia. So, although additional outside classroom learning is achievable, through self-reading of textbook and educational journals. However, the learning process is taxing and students may be easily demotivated. In recent years, there has been a great interest in developing a wide variety of dental apps for interactive and flexible dental education. To date, none of the developed dental apps were designed for OM teaching and learning. Therefore, we developed an application-based diagnostic tool, ODS3 app, a novel method to teach clinical decision-making in the diagnosing of OM-related disease. The app was designed to supplement rather than to entirely replace the old conventional method of teaching. The objective of the study is to evaluate students' perception on the effectiveness of ODS3 app as a learning tool. We want to know how far the acceptance of UiTM dental students towards the designed app. So basically, this is a cross-sectional study. For the development of the app, the ODS3 app was developed based on the decision tree algorithm in diagnosing oral medicine cases using a stepwise progression method. Since the ODS3 app is a pilot study, only 3 diseases were selected for the app development, which comprises of color lesion, immune-mediated diseases, and oral ulcers. A decision tree is a flowchart used to help the clinicians to reach a provisional diagnosis. It's like a step for you to click on the app to find a definite diagnosis. You can see the layout of our ODS3 app in the poster. For the first layout of the app, it contains the home page which user can click on the oral mucosal lesion icon to start the app. Once you click, the second page containing the 3 lesions will appear, so you click on the related disease, for example, color lesion. Then the third page will appear the possible clinical presentation of the lesion based on the case. So users can continue clicking the app based on the clinical presentation until get the possible provisional diagnosis. Despite a few diseases can have similar clinical presentations, for example, white lesion, the advantage of the app is to help the clinician to narrow down the possible clinical diagnosis by differentiating them according to the appearance, characteristic, and site of the white lesion. The Progressive Web app was designed and developed using Quasar framework with Vue.js and was made available for iOS and Android users, mobile phones. Once the app was completed, we constructed a 5-point Likert scales ranging from strongly disagree to strongly agree to evaluate the perception of the students on the effectiveness of the app. For the content validation, the questionnaire was validated by 2 specialists in the relevant field and also from UiTM undergraduate dental students in the 3rd year to gain their feedback on the overall acceptability of the questionnaire in terms of length, understanding, and language clarity. As for the questionnaire, it consists of 5 sections. For section 1, we ask about the demographic data. Section 2 assesses the app content in terms of sufficiency, relevancy, and supplemented clinical features. Section 3, we assesses the app design in terms of structure, layout, and reliability. For section 4, focuses on the app aptness to evaluate its practicality. And the last part, section 5, we evaluate the effectiveness of learning using ODS3. The link to the ODS3 app was distributed to the students, and the students are required to peruse the ODS3 app prior to answering the questionnaire.
Assalamualaikum, my name is Tengku Fatin and I will continue with the result. From a total of 164 Year 4 and Year 5 students, 100 responses were written, consisting of 60 Year 4 students and 40 Year 5 students, indicating a response rate of 60% equal to 60 and 40% respectively. From the figure 2, a vast majority of the students, which is 98%, prefer learning through the combination of conventional lecture and or these 3 apps. Meanwhile, 1% of them respectively answer to receive lecture alone and app alone. 92% of the students agree that the app design is user-friendly and the layout is well structured. as figure 1 shown in the poster. 85 of them agreed that the layout is visually attractive. Next, 97 of the students agreed that Audis3 app promote rapid self-revision, and 95% of the students found that the app is practically useful for undergraduate dental students. All the answered questionnaire data were collected and summarized into Table 1 that have been presented in the poster. For the discussion part, in overall, students' perception was positive towards the use of Audis3 app to complement the conventional teaching method. Audis3 app was perceived to have a significant impact on learning in the vast majority of students as it enhanced student understanding by providing an overview of the whole content of oral medicine subjects and the main key point in diagnosing diseases. Foster et al. 2011 in their study inferred that most dental students showed a positive attitude towards the use of technologies as teaching tools. So, for this research study, the clinical pictures in Audis3 app aid students to get familiar with oral diseases since they get little clinical exposure due to the limited clinical sessions. Not only that, the convenient use of Audis3 is envisaged to replace the conventional revision session and to aid students in last-minute preparation and revision for their examination or even clinical sessions, as the app reduces the hassle to open up a textbook to find information. Audis3 app is surmised to greatly benefit the students by improving their diagnostic skills, cultivating their interest in learning oral medicine, and enhancing their knowledge on the clinical presentation of oral diseases. With that, we end our presentation with a conclusion that the use of dental app should be encouraged in dental education to foster cognitive interest and engagement among the undergraduate dental students who live are proliferated by digital technologies. With that, thank you.
Thank you, presenters. Now we welcome the judges for the Q&A session.
Yeah, Assalamualaikum, Hanan and Tengku Fatin. That was a very good presentation. And I think it's good that just one question before I further ask you other questions. Did you develop the app yourself? Is developing the app part of your study? Because you
No.
didn't mention anything about it.
No, the app was developed by our supervisor, Dr. Eddie
Alright.
and Dr. Nani.
I think that should be mentioned because when you presented, it seems that you developed the apps yourself lah. So I was like, wow, undergraduate students developing app, that is a good thing lah. Okay, okay. In terms of response rate, you only obtain about 65%, correct? Response rate.
Yes.
Yes. Fatin, kau yang cakap tadi?
Atin?
Yes, the response rate, 50% is year 4 student.
50% year 5 student. Total response rate?
60%.
60%. All right.
From year 5.
The sample population is only year 5?
Year 4 and year 5.
Okay, but total response rate is 60% from year 4 and year 5. What's the total response rate?
100%.
Tak boleh lah 100%. 100%?
I mean,
you can't get
60% from year 4.
Okay.
40% from year 5.
Is that a response rate?
The response rate is 61% for the total.
61%, eh?
Yes.
Okay. Did you 61% is actually okay lah, acceptable lah. But did you make an effort to improve your response rate during data collection?
Spam in the website to encourage students to answer the questionnaire, and we send emails to
You're breaking, Fatin. I tak dengar sangat. I can't. Sorry Fatin, I can't hear you. I think your voice breaking. I tak boleh dengar but it's okay. I think maybe you have done some efforts lah. Alright. I'm surprised. Okay. One last question before I pass over to AP Aida. Okay, I think this is a good app because I think you have said that OM is quite a dry subject, right? I have to agree to that. But okay, what is the next step? I mean, if you're given a longer data collection period, all right, what is the next step that you think you should do to validate the effectiveness of the apps in improving students' learning? What is the next step? What sort of research that you think you should conduct? Because this one is only their perception, right?
Yes, yes. So first of all, we want to upgrade the app by completed it with the
Cepatnya.
syllabus.
Okay.
Okay. Syllabus
Alright.
in
But
oral
okay.
method. And we want to add more content like we put quiz, or we put example of the clinical cases in the app, and also to test about the effectiveness we can do before and after test of using the app.
Yeah, I mean maybe you can compare it with their exam results.
Yes, yes, yes.
And their performance in clinic, OM clinic. That
Yes.
would really validate the effectiveness, right? Okay.
Yes.
Prof. Aida?
Thank you very much, and well done to Hanan and also Tengku Fatin. Thank you, AP Dr. Norintan. So actually, my wording question is also like, did you do the apps? But has been answered. Okay, and I'm glad because I think the apps is actually useful for teaching and learning. But do you think these apps is also can be useful for a clinician? Perhaps not a specialist, but maybe a general dentist in coming up with a diagnosis?
Yes, of course, because the app is the main point is to know the diagnosis of disease and to narrow down clinical diagnosis. So it will be benefit too for the clinician to use.
Okay. Has these apps been used in the teaching and learning yet, or is it still under
No.
test?
No, Prof. This is a pilot study, still undergoing the development of the app.
Okay. Right. So I'm looking forward for that apps to be used in our course. Yeah, in our OP, right? Is it OM and OP together?
Yes, Prof.
Okay. Yeah. Congratulations. That's all from me.
Thank
Alright,
you.
can I just add for your conclusion, when you're doing write-up, your conclusion must must be tied up with your objective. Okay, tadi tu tak related to your objective. Another one, you have references list, but it doesn't appear in the text. Dalam poster tu tak tahu siapa yang cakap, but there's a reference list. Alright, there's some technical issue lah. Alright, thank you.
Thank you, Prof. Thank you all judges.
Thank you, judges and presenters. Before we move on to the next presentation, we would like to present the e-certificates for the presenters for your participation in the symposium. Sorry, we are having a technical problem. Please wait for another 3 to 5 minutes before we continue to the next presentation. Okay, welcome back. Sorry for the technical difficulties. Now we move on to the next poster presentation. Let's welcome Shira Cynthia Islami from Universitas Indonesia, who will be presenting on the role of oral health awareness and knowledge in smoking cessation motivation adolescents in Jakarta.
The Honorable Board of the Judges, committees, my fellow participants, and the audiences. Good afternoon. In this very special occasion, let me, Shira Cynthia Islami, a dental student from Universitas Indonesia, to present you my research that is supervised by Dr. Febrina and Dr. Ambar, entitled The Role of Oral Health Awareness and Knowledge in Smoking Cessation Motivation, a Study Among Adolescents in Jakarta. In 2018, Indonesia's national health data revealed that the majority of smokers in Indonesia started smoking at the age of 15 to 19 years old. Moreover, the report also recorded the escalation in the number of teenage smokers from 7.2% in 2013 to 9.2% in 2018. Therefore, measures are needed to protect our young generation from smoking and also helping those who have smoked to stop smoking. In order to do so, we need to have strong evidence. The Nazir et al. Study in 2017 suggested that knowing the bad effects of smoking on oral health can prevent teenagers in Saudi Arabia from smoking. Meanwhile, in Al-Abdullah et al. Study in 2019, knowing the things mentioned can increase adolescents willing to stop smoking. The objective of this study are to discover the level of awareness and knowledge about the effects of smoking on oral health and smoking cessation motivation among adolescents in Jakarta. In this study, we use a knowledge and awareness questionnaire by Al-Abdullah et al. Study and smoking cessation motivation questionnaire by Jolie et al. Those questionnaires have undergone cross-cultural adaptation. The process included a translation into Indonesian language and validity tests. The translation process itself consisted of several steps. The first step is translation into Indonesia by 2 translators, a sworn translators, and one from medical background with TOEFL score above 550 qualification, and then back translated into English with a different sworn translator. The questionnaire then discussed in a panel expert for the final form. Thenceforth, we conducted a reliability and validity test to generate a validated questionnaire. The validated questionnaire was then filled by high school students in Jakarta remotely through Google Form. Those who had electronic and internet limitations were excluded in this study. The data were then processed in SPSS with specific tests depending on the type of the data. As a result, 552 high school students covering all areas in Jakarta participated in the study. Most of the students were aware that smoking jeopardized oral health. Many of these students had little knowledge about specific effects of smoking on oral health. This might happen because the awareness-related question asks more general information compared to the knowledge-related question. The awareness data processed using simple logistic regression revealed that female students who reported never smoking over a short duration of time, or having the intention to quit smoking, were all more likely to be aware than their control group. In relation to this knowledge, students who never smoked also displayed higher knowledge levels than their peers. These results were in line with previous study, which is raising awareness about the effect of smoking could be an effective way to protect adolescents from smoking. A cognitive dissonance theory from Leon Festinger could also explain why students with longer duration of smoking were less likely to be aware. The theory mentioned that when a change in behavior is difficult to achieve, such as quitting smoking, a change in attitudes occurs instead. Given the difficulty of quitting smoking, the theory would predict that smokers are more likely to adjust their beliefs to justify their behavior than they are to change their smoking behavior. Here, we can see that the level of smoking cessation motivation was low on 22 out of the 51 students reporting the motivation to quit. There were linear correlations between motivation scores and academic score, cessation duration, smoking period, and the intention to quit smoking. Regarding the academic scores, study conducted in Europe by Robert et al. Also mentioned that students who smoked had low academic grades. Speaking of the strong correlation of cessation motivation with cessation duration, trans-theoretical methods stated that the person who has quit smoking for more than 6 months are in the maintenance stage. In this stage, they are now more resistant to the unwanted behavior. Therefore, motivation and confidence is increasing. The possibility of a return to the previous steps of changed behavior gets smaller by the time, but caution is necessary at all times. The intention of smoking correlation to smoking cessation motivation also appeared from another study conducted by Kim et al. They mentioned that the intention of smoking was a determinant of smoking cessation in adolescents. There was no statistically significant differences between awareness and knowledge with smoking cessation motivation. Previous results mentioned that students who never smoked were more likely to be aware and had higher knowledge. Unfortunately, this does not work for students who have smoked, because they were already under the influences of nicotine, which increases their addiction to smoking. This is also explained why students who had longer durations of smoking also had lower smoking cessation motivation. This group needs more than an education regarding the effects of smoking on oral health to be able to help them to stop smoking. In conclusion, awareness and knowledge regarding the effects of smoking on oral health might have a role in preventing smoking, but was not compelling enough in promoting smoking cessation. The challenge may be related to addiction that correlates with smoking duration. This brings us to the end of my presentation. I'd like to thank all the committees and judges for this very special opportunity. Thank you.
Thank you, presenters. Now we would like to invite the judges for the Q&A session.
Hello, Assalamualaikum, Shira. Welcome to Malaysia online, although, right? You can hear me, right, Shira?
Yes, I can hear you
Okay,
clearly.
right. All right, okay. Okay, congratulations. I think it was a good presentation. You have a very large sample size, right? 552 high school students in Jakarta participated in your study, right? But do you have any basis for this sample size calculation?
Yeah. So actually the minimum sample size was only 385.
Based
But
on what?
based on the based on I use the from Slovene.
From?
Slovene. Slovene.
What is that?
Slovene minimum sample calculation.
Oh, so you did not, you did not calculate your sample size based on the prevalence of awareness or oral health knowledge on smoking cessation?
Yeah,
The basis, the rationale of sample size calculation.
Because there was no at the time there was no other study in Jakarta that calculated that studied the awareness and knowledge
Alright,
regarding
but
the effect of
okay.
smoking in Jakarta.
But if there's none in Jakarta, you can also use data from outside Jakarta and even in Southeast Asian, all right, to calculate your sample size. But however, your sample size is very large. But what's your response rate actually?
My response rate, I actually, since we use online distribution, we don't know we didn't know how many students got our Google form.
How did you distribute the online questionnaire?
I distribute the questionnaire first from the school's teacher.
I see.
So actually, the school teacher give the Google form to their students.
Right. So actually, you can ask the teachers the number of students that participated and the number of students that did not participate. Then you can gauge your response rate from there. Okay. One last question. You said that you excluded high school students with no electronic or internet limitation, right? What is the implication of excluding these students to your study findings? Do you think you get different results?
Since we in this pandemic era, we only can use the questionnaire from online. So we
Betul. Tapi if you have included that, if there is no pandemic and you are able to include everybody, would you think there will be any difference in your study findings?
yeah, I think there will be a huge difference.
In what way?
Maybe we can get larger sample size.
Of course.
And
In
then
terms of
the
results?
variable will be more variation. Like in my study, the females are more than the males. So I think if there's no pandemic, we can control the variable based on the gender.
Okay, all right. Pass this to Puan Yati next.
Thank you, IP Dr. Intan. Assalamualaikum, Syira.
Waalaikumsalam.
Okay, congrats for the good presentation. I have one question. So you collected 552 samples. Okay, your respondents are high school students. From how many schools that actually you collected
From
the sample?
from 72 schools.
Okay, so how you actually choose your respondent, or what type of sampling that you use? Is it a random sampling, or you only choose the final year students, for example, stratified sampling?
We conducted the convenience sampling technique. So based on the someone we know, they have relation to high school students. So we distribute our questionnaire from them.
Okay. So it's reported here that the level of smoking cessation motivation was low, about 43.1% out of 51 students. So do you think what is the factors that contribute to this? Do you have any idea, maybe from the other the demographic information that you obtain from the respondent, the background of the patient or the respondent, for example?
So we only calculate the smoking cessation motivation on the students that smoke and also have have stopped smoking to uh, to see that even whether they have stopped smoking, are they still have the high smoking cessation motivation. I think the thing that contribute on the smoking cessation motivation was the gender, since most of the smokers are males, and they also stated that they have friends that are smoking also, and also they are on their age on their age that on the age that likely to smoke.
Okay, thank you. That's all from me.
Thank you.
Thank you, judges and presenters. Before we move on to the next presentation, we would like to present the e-certificates for the presenters for your contribution in this symposium.
Thank you.
Now let's move on to the next presentation. Please welcome Alvina Vicky and Divya A from Institute of Dental Sciences, who will be presenting on population prediction using dental radiographs.
A very good day to everyone present here. I'm Ms. Alfina, and my co-presenter Ms. Divya would like to present our poster on population prediction using dental radiographs. Let's look into the brief insight of anthropology. It is a scientific study of humanity, mainly concerned with human biology, human behavior, and societies. Dental anthropology focuses on the development, evolution, and variability of teeth and related orofacial structures. Anthropology have numerous applications. They are as follows. Understand humanity better than any other single course of study, gender differentiation of human remains, anthropological identification of skeletal remains, and it is also helpful in mass disasters.
Let's talk about the application of forensic odontology in anthropology and race differentiation. Forensic odontology plays a very important role in identification in man-made or the natural disasters which cannot be identified through the conventional means as DNA fingerprints. Morphological characteristics of teeth like carabellized stride, shovel-shaped incisors, etc. helps to differentiate races. Racial differentiation is needed for the identification of the victim population, gender differentiation, and to identify specific features in mass graves and collection of the ante-mortem records for the investigation purpose.
Kodagu is a small district in the southernmost tip of the state of Karnataka bordering Kerala with a distance less than 50 kilometers. The population of Kodagu has large number of migrant population from the state of Kerala. It is a place which is more prone to floods and landslides, which results in loss of life and victim identification becomes difficult. The aim of our study is to identify significant features on mandible that differentiate between Kodava and Kerala population. We have taken 10 panoramic radiographs each of Kerala and Kodagu population between the age of 18 to 25 years. We have excluded the radiographs of patients who have undergone orthodontic treatment, who have major pathologies, either jaw and debilitating diseases affecting bone, etc. We have digitally measured the parameters as follows: intercondylar distance, intergonial distance, condylar and coronoid distance, condylar notch depth, and distance between condyle and coronoid. Image analysis was done by using the GIM software. Both linear and angular measurements was done. All results tabulated were subjected to statistical analysis. The statistical analysis showed that the difference between the values of Kodava and Kerala population was high, and the difference within the valleys of Kerala and Kodava population was low. This was statistically highly significant with an F value of 0.000. Intercondylar distance, the distance between the coronoid and the condyle, the depth of the coronoid notch and the gonial angle and the intergonial distance are the effective indicators of the population among the individuals of the Kerala and the Kodava populations. The drawbacks of our study are large sample size were not considered, standardizing in taking radiographs, we excluded the migrant population, larger age group were not considered, we included only the age group between 18 to 25 years. Our poster discusses an easy method that will allow for differentiate between the individuals of Kerala and the Kodava population using dental radiographs. Thank you.
Thank you, presenters. Now we would like to invite the judges for the Q&A session.
Can I invite Prof. Aida first?
Okay.
Is it possible?
Thank you, Valentin. Good afternoon to
Good afternoon, ma'am.
right, Divya and Alfina. Thank you for joining
Yes, ma'am.
us. Yeah, and welcome to Malaysia virtually. So, thank you very much for your presentation. It was a very good presentation. I would like to know.
Thank you, ma'am.
Welcome. May I know the size of your sample?
Ma'am?
May I know your sample size?
10 radiographs, ma'am, each of Kerala and Kodava population.
Okay. And do you think and what type of statistics analysis that you carry out to come out with the statistical outcome?
The statistical analysis showed that it was highly significant with a value of 0.000.
Okay, and what analysis that you carry out?
ANOVA statistical analysis.
Okay, and do you get and do you think that with your 10 sample size that you can do ANOVA parametric analysis?
Ma'am,
Afina,
ma'am, it's 1 second, ma'am. Yeah, yes,
sorry?
ma'am. Can you just, sorry, ma'am, I was not able to hear. Here in India, there is a pandemic and then we are having lockdown, ma'am. So we both, like me and my co-presenter, we are traveling back to our home. So there are some network issues, ma'am. So can you just repeat the question once more?
Okay, do you think that the 10 sample size of each population can be analyzed using ANOVA, using a parametric analysis?
Yes, ma'am.
Did you get well-distributed data? Okay, it's okay. Then is Kodava and Kerala population the majority in Karnataka?
Yes, ma'am. Kodava district in Karnataka, and there are more migrant population from Kerala. So there is more in Kodagu district. There is more population from Kerala, and also there is Kodava population.
Okay. All right, I shall pass the Q&A session to Prof. Norintan.
Okay, hello, Alfina and Divya. I think your
Hi,
study
ma'am.
is I think your study is very interesting, especially the rationale, because I think you're trying to develop a system where if disaster happens, then you'll be able
Yes,
to
ma'am.
identify, right, who are from from which ethnicity. But again, I wanted to ask also just now is whether Cordova and Kerala is the major races in Karnataka, and you have answered that. But again, on the radiograph that you have evaluated, the 10 radiographs, do you have the characteristics of the patients in terms of the age, in terms of the gender? Is there any, do you have the characteristics roughly?
Yes, ma'am, sure.
18 to
We
25
can
years old.
Sorry?
We consider age groups from 18 to 25 years.
18 to 25, like,
Yeah.
so that is the range of the age group. What about the, in terms of gender? You have it?
No, ma'am, we didn't consider about the gender. We only took age group
So
from 18
it
to
could be
25.
all females or all males, right? Could it be?
Ma'am, yes, ma'am, we have taken both people, male and female, ma'am. We didn't consider
Okay.
gender, ma'am, but age was considered between 18 to 25 years.
Why did you only consider this age?
Because at that age, it will be stable. The growth of the things will be
Because
Hello, I can hear Alfina, but not Divya. Maybe Alfina can help to answer.
Yes, ma'am. Ma'am, there's no the mandible is actually well developed, and then there is no changes in the mandible. So at that age, when we take the radiographs, we would able to recognize we were able to measure the intercondylar distance, bonial angle. It was fine and well developed, ma'am. We considered a radiograph of that age.
All right. If disaster happens in Karnataka to an elderly
ma'am.
person like me, would you
Yes,
be
ma'am.
able to identify whether I am of the Kadava or the other races? Would you be able to do that?
Ma'am,
Okay, let's say
now
that I am 50 years old.
yes, ma'am. Ma'am, that's a drawback of our experiment, ma'am. We have just considered the age group. We have not measured, we have not taken radiographs of people more than that age. So,
Right. But what's your
we are planning to.
expectation based on your literature review? What's your expectation if something were to
Yes,
happen to
ma'am.
an elderly? Yeah.
Yeah, we will be able to find it and differentiate, ma'am.
Based on all the characteristics that you have stated here, in terms of the depth of coronoid notch, intercondylar distance, you think there would be also similar differences of this age group, elderly? Maybe, yeah. Okay. All right. Thank you so much. Thank you for your effort. All right.
Thank you.
Good luck.
Thank you, ma'am.
Yeah.
Thank you, judges and presenters. Before we move on to the next presentation, we would like to present the e-certificates for the presenters for your participation in this symposium. Now let's move on to the last poster presentation for this afternoon. Please welcome Jennifer Pugh and Gayatri S. Chandran from Crook Institute of Dental Sciences, who will be presenting on salivary pacemakers.
Good day to all. We are here to present the poster on the topic salivary pacemaker. As you know, saliva has many important functions like mechanical cleansing action, solubilization of food, detritus dilution, bolus, oral cavity lubrication, remineralization, and maintaining the integrity of oral mucosa form. It also provides antimicrobial activity and a buffer that protects the teeth from decay. People with xerostomia often complain of eating, talking, saline, and wearing dentures. Prosthetic users may have problems with prosthetic retention, oral mucositis, and a tongue attached to the palate. Patients with xerostomia often complain about dysgeusia, glossodynia, increased thirst, especially at xerostomia can cause a significant increase in the thyroid activity, thyroid enlargement, inflammation, and the cracking of lips, glossitis, oral mucositis, oral candidiasis, salmonellitis, bad breath. Usage of artificial saliva, chewing sugarless gums, sucking sugarless candies provide symptomatic relief, but likelihood of the recurrence is high when the treatment is stopped. The use of medications like pilocarpine, even though the provided relief poses an adverse effect on long-term use. The salivary pacemaker based on neurostimulation on salivary gland, which provide little or no adverse effect. Now coming to the integral concept, salivary pacemaker. They are the neuro-electrostimulating device that increases saliva secretion. In this, there are three generations. The first generation has a prop kept intraorally for few minutes, and the second generation of a removable appliance same like a moped, and the third generation is implant-based.
Coming to all three generations of salivary pacemakers in detail. First generation electrostimulating devices. A device was marketed by the name Saltron to increase salivary secretion via neuroelectrostimulation. The user is supposed to apply the probe to the intraoral mucosal surfaces between the dorsum of the tongue and the palate for a few minutes each day, which deliver a stimulating signal to sensitive neurons of the mouth to induce salivation. It is seen that when delivered repeatedly led to an immediate response, increase of salivation as a result of the stimulation, and a cumulative long-term response, sustained increase of basal salivary flow rate, as well as subjective improvement in symptomatic xerostomia. First generation neuroelectrostimulation device consisted of a handheld probe tipped with stainless steel electrodes and a console that housed a battery and the electronic signal generating power source, the size and shape of which was similar to a video or CD player. These are having some disadvantages: large size, high price, lack of user-friendliness, etc. Coming to second generation devices, the second generation salivary neuroelectrostimulator resembles a mouth guard, as it is a customized removable intraoral appliance produced by using patient's own teeth pattern molds. It has a horseshoe-like shape and fits on the lower dentition. The electronic components are embedded within the appliance to allow safe and contamination-free intraoral application. It is easy to use, and a remote control permits the patient to communicate with the device and modify its functions. The device was effective in reducing dryness of the mouth during application and up to 10 minutes after its removal. Second generation removable devices consist of three components: a miniaturized electronic stimulator that has a signal generator, power source, and a conducting circuitry, an intraoral removable appliance, and an infrared remote control. Next, dental implant-based third generation intraoral device. A compact neuroelectrostimulating device was designed to cater the needs of patients who require constant stimulation of salivary gland to be permanently implanted into the oral cavity. The components of the second generation device were packed into a device that has the dimensions and shape of a molar tooth. It's convenient since it avoids the repeated application and removal of a splint-based stimulator. This device can be mounted on commercially available osseointegrated implant. A wetness sensor has been embedded into the device to detect changes in wetness or dryness.
Now coming to the conclusion. Xerostomia, the subjective complaint of dry mouth and hyposalivation, has been a matter of concern since ages. This concern, along with the increased risk of oral diseases in patients, has led the clinicians to diagnose and provide preventive and a definite treatment to achieve oral comfort and function. At present, management of xerostomia patient is quite challenging for prosthodontists, with these patients who hyposalivation and xerostomia, who require long-term therapy. Second and third generation intraoral neuroelectrostimulating device may offer a new non-medical means of treatment. Thank you.
Thank you, presenters. Now we move on to the next. Let's welcome the judges for the Q&A session.
Okay, hello Jennifer and Gayatri. How are you?
Fine, ma'am.
Right. I'm glad that you are able to join us. You missed your turn just now, right? Okay. Okay, when I look at your topic, it just says salivary pacemakers. Right? What do you think of your
Yes, ma'am.
topic, salivary pacemakers? You think that it tells the readers about the objective of your study? You think that you should, how can you improve the title of your research? How would you improve it? Because I think it's very broad. Salivary pacemakers. Okay, so what then? If you're given a chance, how would you improve the topic, the title?
Ma'am, advancement in treatment of xerostomia. I can use that title as well because the xerostomia is a most common problem these days. So I may use title.
All right, guide. To guide you to develop a good topic is to look back at your study objectives. So what is your aim actually in this study? What's your main aim, objective? What do you want to do?
Main objective is treatment of xerostomia problems without adverse side effects like some anti-sialogogus medicines, pilocarpine, candies can give a symptomatic relief, but after prolonged use, it may have some side effects.
Right, because when I look at your abstract, Gayatri, when I look at your abstract, actually you aim to present recent developments for the treatment of xerostomia, right? By looking particularly at this electro simulation, right? So that should be roughly the topic. So with guide, you give some audience some ideas of what you're doing, all right? So because I think your topic is quite broad, all right? Okay, when you did the literature search, why did you stop at 2018? Because now it's 2021, right? But why did you stop at 2018? Because, okay, when I read your methods, literature search between 1986 and 2018 was carried out using PubMed, whatever. Why did you stop at 2018 and not at least 2020? Jennifer, are you able to answer this? All right. Okay, it's okay. Gayatri, do you understand my question?
Ma'am, can you please repeat the question because
All right.
we are traveling
Okay.
now.
All right. I see. In your methods, in your abstract, you said that literature search between 1986 and 2018, or maybe 2018 was carried out. Why did you stop at year 2018 when it's already 2021 now?
Ma'am, because this advancement started from 2018 and it's developing more now. But the actual development started in 2018. So we used.
So that means it's like 2018 to 2020. Why? Because you stated here 1986. You search for papers published from 1986. Right, but it's okay. All right, you can. Do you have my last question? Do you have any inclusion criteria when you did your literature search? Inclusion criteria. Do you have any inclusion or exclusion criteria? No?
Hello?
No, yeah? Yeah, do you have any inclusion criteria?
No, ma'am.
It's okay. All right
I
then.
don't know about
Okay,
it.
I'll pass the floor to Madam Yati.
Thank you, IP Dr. Intan. Hi, Jennifer and Gayatri.
Ma'am. Good afternoon, ma'am.
Okay, good afternoon. Thank you for your presentation. Okay, my question, what is the total number of your articles? You abstracted how many articles?
3, ma'am. From 3 articles we abstracted, ma'am.
3 articles, but in the abstract it's mentioned 22 studies. Is it a total 22 and then you choose 3, or what's the initial numbers of the article before you apply the exclusion criteria? Did you use any keywords to search for the article? Hello, can you hear me? Can you hear me? Did you use any keywords to search for the article? Keywords?
Yes, ma'am. Keywords are xerostomia.
Ma'am, you used to.
Sorry, I can't hear you, Jennifer. So maybe Gayatri, your line is clearer. What's your keywords? Xerostomia?
Ma'am?
Yeah.
Ma'am, salivary pacemakers, generation,
So
implant-based neuroelectrostimulators,
okay.
and so on, ma'am.
So from that search search keywords, how many articles that you got from the big initially? You okay, it's okay. Because you mentioned
I don't have the
22.
right knowledge, ma'am.
Okay, it's okay. I think that's all from me. Thank you.
Thank you.
Do you mind if I ask one question?
Please do.
Yeah, thank you. Well, I've seen this already. A type of publication on salivary pacemaker. And what makes your study different?
Like this was a random topic we took. We want to study about we first years. So being first years, we wanted to learn more about it. So we choose that topic.
Okay.
Oh, you're first year dental student.
Yeah, ma'am.
Yes, ma'am.
First.
I
And first
see.
solely, ma'am.
Okay.
Wow. Well done. Good exposure for you. Thank you very much.
Very early
Thank you,
exposure.
ma'am. I'm sorry for the disturbance. Due to pandemic, we are traveling back to our home. Sorry, ma'am.
Okay. All right.
It's
Take
okay.
care. Take care, everyone.
Have a safe journey.
Thank you, ma'am. You too, ma'am.
Bye.
Thank you so much. Bye, ma'am.
Welcome.
Thank you, judges and presenters. Before we end this session, we would like to present the e-certificates for the presenters for your participation in this symposium. Okay, we have come up. This concludes the poster presentation for today. Thank you all for attending, and we hope you have learned and enjoyed along the way. Hope to see you again tomorrow at 9 a.m. Thank you.